for public health practitioners to be able to curb the pandemic. The School of Public Health has grown into now we have 6 big departments where we are training people in population and reproductive health, occupational and environmental health and safety, health services management, planning and management, and we are also training people in health education and promotion. Apart from that, the School of Public Health has also grown up, and now we are also training in global health. The area of global health is extremely important, especially in the area of COVID-19, where we have to put pandemic preparedness at the fore. As a country, we don't have to wait for another pandemic to strike before we start running around trying to control or contain the disease. And therefore, we are training people to be ready that whenever any of these issues arise, we will be in a good position as a nation to protect ourselves. I always tell my students that diseases do not require passports to travel. People travel around the world. So if people are carrying diseases, even on the plane, you can spread some of these diseases. And also, you can go to certain places and just pick a disease, and it's just a flight away from your country. And when you come back, it can be spread. So these are, and it's amazing, these are the issues which confront us nowadays, and many people are now choosing a career in public health so they'll be better placed to address some of these issues when they arise. And that's where the School of Public Health has a vision to train a high caliber of public health practitioners to meet these challenges. Well, the School of Public Health exists to promote the training of public health personnel in public health. We want to be the preferred choice for training students and all caliber of people in this area. The issue of public health is now at the fore of many issues, especially with the advent of COVID-19. So many people have now become interested in public health because when COVID-19 broke, we realized the need for public health practitioners to be able to curb the pandemic. The School of Public Health has grown into now we have 6 big departments where we are training people in population and reproductive health, occupational and environmental health and safety, health services management, planning and management, and we are also training people in health education and promotion. Apart from that, the School of Public Health has also grown up, and now we are also training in global health. The area of global health is extremely important, especially in the area of COVID-19, where we have to put pandemic preparedness at the fore. As a country, we don't have to wait for another pandemic to strike before we start running around trying to control or contain the disease. And therefore, we are training people to be ready that whenever any of these issues arise, we will be in a good position as a nation to protect ourselves. I always tell my students that diseases do not require passports to travel. People travel around the world. So if people are carrying diseases, even on the plane, you can spread some of these diseases. And also, you can go to certain places and just pick a disease, and it's just a flight away from your country. And when you come back, it can be spread. So these are, and it's amazing, these are the issues which confront us nowadays, and many people are now choosing a career in public health so they'll be better placed to address some of these issues when they arise. And that's where the School of Public Health has a vision to train a high caliber of public health practitioners to meet these challenges. Well, the School of Public Health exists to promote the training of public health personnel in public health. We want to be the preferred choice for training students and all caliber of people in this area. The issue of public health is now at the fore of many issues, especially with the advent of COVID-19. So many people have now become interested in public health because when COVID-19 broke, we realized the need for public health practitioners to be able to curb the pandemic. The School of Public Health has grown into now we have 6 big departments where we are training people in population and reproductive health, occupational and environmental health and safety, health services management, planning and management, and we are also training people in health education and promotion. Apart from that, the School of Public Health has also grown up, and now we are also training in global health. The area of global health is extremely important, especially in the area of COVID-19, where we have to put pandemic preparedness at the fore. As a country, we don't have to wait for another pandemic to strike before we start running around trying to control or contain the disease. And therefore, we are training people to be ready that whenever any of these issues arise, we'll be in a good position as a nation to protect ourselves. I always tell my students that diseases do not require passports to travel. People travel around the world. So if people are carrying diseases, even on the plane, you can spread some of these diseases. And also, you can go to certain places and just pick a disease, and it's just a flight away from your country. And when you come back, it can be spread. So these are, and it's amazing, these are the issues which confront us nowadays, and many people are now choosing a career in public health so they'll be better placed to address some of these issues when they arise. And that's where the School of Public Health has a vision to train a high caliber of public health practitioners to meet these challenges. Well, the School of Public Health exists to promote the training of public health personnel in public health. We want to be the preferred choice for training students and all caliber of people in this area. The issue of public health is now at the fore of many issues, especially with the advent of COVID-19. So many people have now become interested in public health because when COVID-19 broke, we realized the need for public health practitioners to be able to curb the pandemic. The School of Public Health has grown into now we have 6 big departments where we are training people in population and reproductive health, occupational and environmental health.
Our faculty was established about 15 years ago from the then School of Medical Sciences. Developing students who are human-centered, innovative, and collaborative has actually made our faculty an ideal environment for those who care for the health of their people. Our trained nurses, midwives, laboratory scientists, sonographers, and sports and exercise scientists find their lasting experience from this place.
I realized there was a problem in my society. People building up weight, pot belly everywhere. I wanted to solve that problem, and I knew KNUST, precisely Sports and Exercise Science Department, would give me all the answers I needed. So I took up the challenge. And since I came here, it's amazing. I've been able to build confidence in order to help my clients, to give them the best and what is going to help them.
Our lecturer and I have studied small blood vessels in the brain by ultrasound imaging. Our objective is to be able to identify abnormal vessels in the brain in stroke patients. As a student, I think this has helped me to understand the organization of the vessels in the brain in the management of stroke.
Our students have access to well-equipped skills laboratories here on campus for pragmatic academic endeavor that unite their minds and hearts for a transformative experience. Our collaboration with well-equipped health facilities like Confanoche Teaching Hospital, Kumasi South Regional Hospital, and Kumasi Center for Collaborative Research has given our students the opportunity to solve real-time health problems with modern technology before they even leave campus.
KNUST's collaboration with KCCR give we students the privilege to come and have our clinical attachment here during the long vac, and this gives us a broader scope of the work. That is the work of the medical laboratory professional, and it also helps us in our research in the final year and gives us clinical orientation for the workforce out there when we graduate.
Over 70% of critical medical decisions are based on laboratory results produced by laboratory professionals. I, as a lady, do not find any barrier between myself and my colleagues, as I'm able to contribute in any form of critical thinking and collaborate with them in producing good and quality results to other health professionals in diagnosing patients.
Our faculty has MOU with some universities in North America and Europe, such as Westminster University, Nottingham University, Bonn University Hospital, and Ramapo School of Nursing. Our research network gives some of our students the opportunity to go abroad and learn other skills, which expose them to global industrial standards.
Aside the nursing practice KNUST has impacted on me, which I could use to make a living after school, KNUST has also given me an opportunity to partake in college exchange program to Florida, which has added to my already known experience here in KNUST. The experience here in KNUST and the one in Florida has changed my view and attitude to work.
The Faculty of Allied Health Sciences, KNUST, offers opportunity for lecturers to take their terminal degrees in various universities, both nationally and internationally. This gives us a blend of experiences from all institutions, which enriches the exposure that we give our students.
I chose this school because this school provides me with everything I need to be a successful midwife. There are so many courses that I could have chosen from, but I chose midwifery because of a personal problem that I encountered when I was young. When I was young, my mother went into labor, and the conditions surrounding her labor was nothing to write home about. She suffered a lot. So when I saw my mother and the pain she was going through, I thought to myself that why not become a midwife so that I can also offer solutions to pregnant women who agonize or who go through pain in the labor ward.
Our curricula within the Faculty of Allied Health Sciences are tailor-made with industry in mind. It is also developed with stakeholder inputs that makes our students to have a competitive advantage on the job. The faculty also gives us opportunities to have seminars on grant writing and proposal writing, and that builds the students' capacity in research. These experiences help our students to develop the skill for practice, for leadership, for research, and for education as a whole.
The experience here positions our students to be better prepared for the job market. Currently, our agents of change are highly spoken of by health facilities in the country and abroad where they get to serve.
So this is the hematology department of Confanoche Teaching Hospital. So we have a lot of students coming through our unit, especially those who are doing medical laboratory sciences. So students from the Kwame Nkrumah University of Science and Technology come here a lot. It is instructive that we note that when they come here, they are able to develop the link between academia and practice. Now, in school setting, what they do is that samples among students are taken, or samples from elsewhere is taken for students to work on. But when they come here, they work on real-time samples, where samples from patients are taken, and they work on them under the supervision of practitioners. And so the benefits that they get is enormous. It develops their confidence, and they are also supervised to do what we do as practitioners. And so our students enjoy us a lot because we have time to teach them whatever they need to know in hematology.
The culture here, our story, and successes keep attracting foreign students from all over the world, but more especially from the sub-region into our faculty. Likewise, during the summer breaks, we get exchange students from North America and Europe for collaborative research and learning.
This is my third year in this country. I've learned a lot, especially in this university. Right now, I'm having a project on tangiasis. So I've found out that this case happens mostly in my country, mostly in the rural areas. So the lectures I've received here in this university have helped me go to deal with that situation at home. I realized that, okay, this is a great chance for me to go and help my country, even though I'm here in Ghana. That's why, as an ongoing project, I'm dealing with Tunga penetrans.
We have undertaken a number of studies to solve local problems. Through collaboration with our partners, we'll be able to find a cure for elephantiasis and river blindness, a disease which affects millions of people in developing countries, including Ghana. There is more to explore and discover here.
My experience in KNUST midwifery has been very fulfilling.
The environment there is stimulating, and I was able to acquire the international breast nursing practice. I believe every student should be given this opportunity.
Do you want to care for the sick, help prevent diseases, and develop purposes towards a healthy society and happy people? It all starts here. You have people to share the journey with, faculty to lead you there, and you have the opportunity to be trained to serve your country and mankind. Our faculty was established about 15 years ago from the Dane School of Medical Sciences. Developing students who are human-centered, innovative, and collaborative has actually made our faculty an ideal environment for those who care for the health of their people. Our trained nurses, midwives, laboratory scientists, sonographers, and sports and exercise scientists find their lasting experience from this place.
I realized there was a problem in my society. People building up with pot belly everywhere. I wanted to solve that problem. And I knew KNUST, precisely Sport and Exercise Science Department, would give me all the answers I needed. So I took up the challenge. And since I came here, it's amazing. I've been able to build confidence in order to help my clients, to give them the best and what is going to help them.
Our lecturer and I have studied small blood vessels in the brain by ultrasound imaging. Our objective is to be able to identify abnormal vessels in the brain in stroke patients. As a student, I think this has helped me to understand the organization of the vessels in the brain in the management of stroke.
Our students have access to well-equipped skills laboratories here on campus for pragmatic academic endeavor that unites their minds and hearts for a transformative experience. Our collaboration with well-equipped health facilities like Confanoche Teaching Hospital, Kumasi South Regional Hospital, and Kumasi Center for Collaborative Research has given our students the opportunity to solve real-time health problems with modern technology before they even leave campus.
KNUST's collaboration with KCCR give we students the privilege to come and have our clinical attachments here during the long vac, and this gives us a broader scope of the work. That is the work of the medical laboratory professional, and it also helps us in our research in the final year and gives us clinical orientation for the workforce out there when we graduate.
Over 70% of critical medical decisions are based on laboratory results produced by laboratory professionals. I, as a lady, do not find any barrier between myself and my colleagues, as I'm able to contribute in any form of critical thinking and collaborate with them in producing good and quality results to other health professionals in diagnosing patients.
Our faculty has MOU with some universities in North America and Europe, such as Westminster University, Nottingham University, Bonn University Hospital, and Ramapo School of Nursing. Our research network gives some of our students the opportunity to go abroad and learn other skills, which expose them to global industrial standards.
Aside the nursing practice KNUST has impacted on me, which I could use to make a living after school, KNUST has also given me an opportunity to partake in college exchange program to Florida, which has added to my already known experience here in KNUST. The experience here in KNUST and the one in Florida has changed my view and attitude to work.
The Faculty of Allied Health Sciences, KNUST, offers opportunity for lecturers to take their terminal degrees in various universities, both nationally and internationally. This gives us a blend of experiences from all institutions, which enriches the exposure that we give our students.
I chose this school because this school provides me with everything I need to be a successful midwife. There are so many courses that I could have chosen from, but I chose midwifery because of a personal problem that I encountered when I was young. When I was young, my mother went into labor, and the conditions surrounding her labor was nothing to write home about. She suffered a lot. So when I saw my mother and the pain she was going through, I thought to myself that why not become a midwife so that I can also offer solutions to pregnant women who agonize or who go through pain in the labor ward.
Our curricula within the Faculty of Allied Health Sciences are tailor-made with industry in mind. It is also developed with stakeholder inputs that makes our students to have a competitive advantage on the job. The faculty also gives us opportunities to have seminars on grant writing and proposal writing, and that builds the students' capacity in research. These experiences help our students to develop the skill for practice, for leadership, for research, and for education as a whole.
The experience here positions our students to be better prepared for the job market. Currently, our agents of change are highly spoken of by health facilities in the country and abroad where they get to serve.
So this is the hematology department of Confanoche Teaching Hospital. So we have a lot of students coming through our unit, especially those who are doing medical laboratory sciences. So students from the Kwame Nkrumah University of Science and Technology come here a lot. It is instructive that we note that when they come here, they are able to develop the link between academia and practice. Now, in school setting, what they do is that samples among students are taken, or samples from elsewhere is taken for students to work on. But when they come here, they work on real-time samples, where samples from patients are taken, and they work on them under the supervision of practitioners. And so the benefits that they get is enormous. It develops their confidence, and they are also supervised to do what we do as practitioners. And so our students enjoy us a lot because we have time to teach them whatever they need to know in hematology.
The culture here, our story, and successes keep attracting foreign students from all over the world, but more especially from the sub-region into our faculty. Likewise, during the summer breaks, we get exchange students from North America and Europe for collaborative research and learning.
This is my third year in this country. I've learned a lot, especially in this university. Right now, I'm having a project on tangiasis. So I've found out that this case happens mostly in my country, mostly in the rural areas. So the lectures I've received here in this university have helped me go to deal with that situation at home. I realized that, okay, this is a great chance for me to go and help my country, even though I'm here in Ghana. That's why, as an ongoing project, I'm dealing with Tunga penetrans.
We have undertaken a number of studies to solve local problems. Through collaboration with our partners, we'll be able to find a cure for elephantiasis and river blindness, a disease which affects millions of people in developing countries, including Ghana. There is more to explore and discover here.
My experience in KNUST midwifery has been very fulfilling.
The environment there is stimulating, and I was able to acquire the international breast nursing practice. I believe every student should be given this opportunity.
Do you want to care for the sick, help prevent diseases, and develop purposes towards a healthy society and happy people? It all starts here. You have people to share the journey with, faculty to lead you there, and you have the opportunity to be trained to serve your country and mankind.
This is a KNUST School of Medicine and Dentistry documentary. This is a KNUST School of Medicine and Dentistry documentary.
Dental education has two parts, where you have the first 3 years where our student will have to do the human biology. So it means that during that first 3 years, the medical students and their dental school, counterpart will have to be in the same class until the level of junior clerkship. Then after, then the candidate will have to come to the dental school proper, where we have the BDS program. So the terminal degree that every candidate will have to acquire before he or she can practice as a dentist in Ghana is what is known as the BDS program. That is the Bachelor of Dental Surgery. So the Bachelor of Dental Surgery is the certificate that you need to be able to practice as a dentist in Ghana. And the whole program duration is 3 years. Most of the time, the first 3 years is done on campus. Then after that, you come to the Konfanochi Teaching Hospital to come and do your clinicals for you to acquire the Bachelor of Dental Surgery. And basically, dentistry is hands-on. So this course involves a lot of practical work. Okay, so you come, we teach you how to take your own dental x-rays. We teach you how to fabricate your own artificial teeth, dentures, teach you how to do fillings and then other advanced prosthetics in dentistry. You are also involved in the x-ray development, oral pathology, oral medicine, and then we have the oral and maxillofacial surgeries. Then we have the other department called the orthodontist and child health. So it's basically a hands-on your program, and the clinical stage is quite intensive. The good thing about dentistry in terms of the training, which is different from other subjects, is that, because it's a hands-on, the student will have to acquire certain clinical competencies before they can pass and become dentists. So in the course of the training, we teach you in the Phantom Head. Phantom Head is like a simulation center where we train our students on most of the procedures. Okay, so you need to pass the Phantom Head room. Okay, that is, as I said, it's a simulation before you can now move to the clinical stage. Okay, or you go to the clinics and then you are encouraged to attend to patients under the supervision of your supervisor, that is the consultants and then the lecturers. So before you graduate, you should be able to do certain procedures. You should know how to comfortably examine a patient, dental patient, extraoral examination, the systemic examination, and you should be able to do basic procedures including dental extraction, fillings, crowns, and bridges, root canals. So we give you requirements, and you need to fulfill all the requirements before we can say that you are qualified to be a dentist.
This is a KNUST School of Medicine and Dentistry documentary. This is a KNUST School of Medicine and Dentistry documentary.
Dental education has two parts, where you have the first 3 years where our student will have to do the human biology. So it means that during that first 3 years, the medical students and their dental school, counterpart will have to be in the same class until the level of junior clerkship. Then after, then the candidate will have to come to the dental school proper, where we have the BDS program. So the terminal degree that every candidate will have to acquire before he or she can practice as a dentist in Ghana is what is known as the BDS program. That is the Bachelor of Dental Surgery. So the Bachelor of Dental Surgery is the certificate that you need to be able to practice as a dentist in Ghana. And the whole program duration is 3 years. Most of the time, the first 3 years is done on campus. Then after that, you come to the Konfanochi Teaching Hospital to come and do your clinicals for you to acquire the Bachelor of Dental Surgery. And basically, dentistry is hands-on. So this course involves a lot of practical work. Okay, so you come, we teach you how to take your own dental x-rays. We teach you how to fabricate your own artificial teeth dentures, teach you how to do fillings and then other advanced prosthetics in dentistry. You are also involved in the x-ray development, oral pathology, oral medicine, and then we have the oral and maxillofacial surgery. Then we have the other department called orthodontics and child health. So it's basically a hands-on your program, and the clinical stage is quite intensive. The good thing about dentistry in terms of the training, which is different from other subjects, is that, because it's a hands-on, the student will have to acquire certain clinical competencies before they can pass and become dentists. So in the course of the training, we teach you in the Phantom Head. Phantom Head is like a simulation center where we train our students on most of the procedures. Okay, so you need to pass the Phantom Head room. Okay, that is, as I said, it's a simulation before you can now move to the clinical stage. Okay, or you go to the clinics and then you are encouraged to attend to patients under the supervision of your supervisor, that is the consultants and then the lecturers. So before you graduate, you should be able to do certain procedures. You should know how to comfortably examine a patient, dental patient, extraoral examination, the systemic examination, and you should be able to do basic procedures including dental extraction, fillings, crowns, and bridges, root canals. So we give you requirements, and you need to fulfill all the requirements before we can say that you are qualified to be a dentist.
This is a KNUST School of Medicine and Dentistry documentary. This is a KNUST School of Medicine and Dentistry documentary.
Dental education has two parts, where you have the first 3 years where our student will have to do the human biology. So it means that during that first 3 years, the medical students and their dental school, counterpart will have to be in the same class until the level of junior clerkship. Then after, the candidate will have to come to the dental school proper, where we have the BDS program. So the terminal degree that every candidate will have to acquire before he or she can practice as a dentist in Ghana is what is known as the BDS program. That is the Bachelor of Dental Surgery. So the Bachelor of Dental Surgery is the certificate that you need to be able to practice as a dentist in Ghana. And the whole program duration is 3 years. Most of the time, the first 3 years is done on campus. Then after that, you come to the Konfanochi Teaching Hospital to come and do your clinicals for you to acquire the Bachelor of Dental Surgery. And basically, dentistry is hands-on. So this course involves a lot of practical work. Okay, so you come, we teach you how to take your own dental x-rays. We teach you how to fabricate your own artificial teeth dentures, teach you how to do fillings and then other advanced prosthetics in dentistry. You are also involved in the x-ray development, oral pathology, oral medicine, and then we have the oral and maxillofacial surgery. Then we have the other department called orthodontics and child health. So it's basically a hands-on your program, and the clinical stage is quite intensive. The good thing about dentistry in terms of the training, which is different from other subjects, is that, you know, because it's a hands-on, the student will have to acquire.
This is a KNUST School of Medicine and Dentistry documentary.
Dental education has two parts, where you have the first 3 years where our student will have to do the human biology. So it means that during that first 3 years, the medical students and their dental school, counterpart will have to be in the same class until the level of junior clerkship. Then after, then the candidate will have to come to the dental school proper, where we have the BDS program. So the terminal degree that every candidate will have to acquire before he or she can practice as a dentist in Ghana is what is known as the BDS program. That is the Bachelor of Dental Surgery. So the Bachelor of Dental Surgery is the certificate that you need to be able to practice as a dentist in Ghana. And the whole program duration is 3 years. Most of the time, the first 3 years is done on campus. Then after that, you come to the Confanochi Teaching Hospital to come and do your clinicals for you to acquire the Bachelor of Dental Surgery. And basically, dentistry hands-on. So this course involves a lot of practical work. Okay, so you come, we teach you how to take your own dental x-rays. We teach you how to fabricate your own artificial teeth dentures, teach you how to do fillings and then other advanced prosthetics in dentistry. You are also involved in the x-ray development, oral pathology, oral medicine. And then we have the oral and maxillofacial surgery. Then we have the other department called orthodontics and child health. So it's basically a hands-on your program, and the clinical stage is quite intensive. The good thing about dentistry in terms of the training, which is different from other subjects, is that, you know, because it's a hands-on, the student will have to acquire certain clinical competencies before they can pass and become dentists. So in the course of the training, we teach you in the phantom head. Phantom head is like a simulation center where we train our students on most of the procedures. Okay, so you need to pass the phantom head room. Okay, that is, as I said, it's a simulation before you can now move to the clinical stage. Okay, or you go to the clinics and then you are encouraged to attend to patients under the supervision of your supervisor, that is the consultants and then the lecturers. So before you graduate, you should be able to do certain procedures. You should know how to comfortably examine a patient, dental patient, extraoral examination, the systemic examination, and you should be able to do basic procedures including dental extraction, fillings, crowns, and bridges, root canals. So we give you requirements, and you need to fulfill all the requirements before we can say that you are qualified to be a dentist.
This is a KNUST School of Medicine and Dentistry documentary. This is a KNUST School of Medicine and Dentistry documentary.
Dental education has two parts, where you have the first 3 years where our student will have to do the human biology. So it means that during that first 3 years, the medical students and their dental school, counterpart will have to be in the same class until the level of junior clerkship. Then after, then the candidate will have to come to the dental school proper, where we have the BDS program. So the terminal degree that every candidate will have to acquire before he or she can practice as a dentist in Ghana is what is known as the BDS program. That is the Bachelor of Dental Surgery. So the Bachelor of Dental Surgery is the certificate that you need to be able to practice as a dentist in Ghana. And the whole program duration is 3 years. Most of the time, the first 3 years is done on campus. Then after that, you come to the Konfanochi Teaching Hospital to come and do your clinicals for you to acquire the Bachelor of Dental Surgery. And basically, dentistry is hands-on. So this course involves a lot of practical work. Okay, so you come, we teach you how to take your own dental x-rays. We teach you how to fabricate your own artificial teeth, dentures, teach you how to do fillings and then other advanced prosthetics in dentistry. You are also involved in the x-ray development, oral pathology, oral medicine, and then we have the oral and maxillofacial surgery. Then we have the other department called the orthodontics and child health. So it's basically a hands-on your program, and the clinical stage is quite intensive. The good thing about dentistry in terms of the training, which is different from other subjects, is that, because it's a hands-on, the student will have to acquire certain clinical competencies before they can pass and become dentists. So in the course of the training, we teach you in the phantom head. Phantom head is like a simulation center where we train our students on most of the procedures. Okay, so you need to pass the phantom head room. Okay, that is, as I said, it's a simulation before you can now move to the clinical stage. Okay, or you go to the clinics and then you are encouraged to attend to patients under the supervision of your supervisor, that is the consultants and then the lecturers. So before you graduate, you should be able to do certain procedures. You should know how to comfortably examine a patient, dental patient, extraoral examination, the systemic examination, and you should be able to do basic procedures including dental extraction, fillings, crowns, and bridges, root canals. So we give you requirements, and you need to fulfill all the requirements before we can say that you are qualified to be a dentist.
This is a KNUST School of Medicine and Dentistry documentary. This is a KNUST School of Medicine and Dentistry documentary.
Dental education has two parts, where you have the first 3 years where our student will have to do the human biology. So it means that during that first 3 years, the medical students and their dental school, counterpart will have to be in the same class until the level of junior clerkship. Then after, then the candidate will have to come to the dental school proper, where we have the BDS program. So the terminal degree that every candidate will have to acquire before he or she can practice as a dentist in Ghana is what is known as the BDS program. That is the Bachelor of Dental Surgery. So the Bachelor of Dental Surgery is the certificate that you need to be able to practice as a dentist in Ghana. And the whole program duration is 3 years.
The Department of Global Health was set up because there was a realization of a need
for training in public health that went beyond local situations. As you know, there has been talk about community health, public health, international health, and now really global health is at the forefront of concerns regarding health in general. The recognition that the world is highly interconnected, and that when there is a sneeze in one part of the world, somebody else will be catching a cold on the other side of the world. That means that understanding these interrelationships and how they work is critical. Also understanding how same problems may pan out differently or may involve different factors in different parts of the world is so critical. And this is why we realized as a School of Public Health that there's a need for training of students in this way of thinking and understanding the way the world works and the way health across the world works, and hence the need for global health. If for anything at all, the COVID-19 pandemic has taught us that everybody is interconnected, and understanding health globally is so critical. We work in tandem with the Ministry of Health, with the Ghana Health Service, and then with the health partners in the country, the WHO, the UNICEF, the World Visions, and the many others that operate in health in Ghana, USAID, the FCDO, and several others. My expectation and hope is that we will be able to get our students to understand the way our Ministry of Health and especially our Ghana Health Service interface with some of these bodies, both locally and internationally. We, for example, have something known as international health regulations. What does it mean if there's an outbreak in a country to report, and how timely should you report? How should you go about the reporting? What does it imply beyond just health for the country and for the continent of Africa and globally? So really looking to interface with the Ministry of Health, the Ghana Health Service, and the health partners to make sure that students have that well-rounded training that they need to be able to operate optimally. Yeah, my expectation is that with the training of more global health professionals and students, we'll be able to have people trained right here in Ghana who have an outlook that goes beyond the country into the entire African continent, and not only the African continent but across the whole world. It's about time that in Africa and in Ghana also, we tell our own story, we describe our own problems, and we are certainly best placed to develop and implement our own solutions. But we cannot know this, we cannot appreciate our problems and develop solutions without a view of the bigger picture. And so what I'm expecting is that we'll have people who are better placed to situate Ghana on the global stage when it comes to health issues, and also beyond that to be able to contribute towards improvement in health outcomes across the continent and globally. Well, a global health student must have many attributes, but the singular most important one I would say is passion. They need to be passionate about health and about health from a global perspective. That's the most important thing. Beyond that, they have to have a certain critical way of thinking, looking at things beyond just what meets the eye, and being able to situate what might be unique to a particular location, to a particular country, within a wider scope or context of the continent or the world. These are very important things that a global health student must be able to do. The Department of Global Health was set up because there was a realization of a need for training in public health that went beyond local situations. As you know, there has been talk about community health, public health, international health, and now really global health is at the forefront of concerns regarding health in general. The recognition that the world is highly interconnected, and that when there is a sneeze in one part of the world, somebody else will be catching a cold on the other side of the world. That means that understanding these interrelationships and how they work is critical. Also understanding how same problems may pan out differently or may involve different factors in different parts of the world is so critical. And this is why we realized as a School of Public Health that there's a need
for training of students in this way of thinking and understanding the way the world works and the way health across the world works, and hence the need for global health, if for anything at all.
Important occasion, particularly on the university's calendar. Morning.
We used to sail all the way to Angola, poaching and catching fish in international waters. So they had first-hand experience. The second thing we did was that next time when they were coming, they would come with a list of the things that they did not understand in the classroom and they wish to learn from us. So that was the second stage. And then finally, when they had passed out and gone, we used to do a 1-year tracer survey. What did that mean? We would invite those persons who had graduated to come for a conference with our fleet manager, all the engineers, or they have not been employed. If they have been employed, what is it that we failed to do as State Fishing Corporation? What is it that the classroom failed to teach them at Nautical College? Those who were not in employment at then, we also found out exactly what. So this then we fed together with Nautical College as well as the Rear Admirals. And I'm glad that the person who also motivated this idea, Rear Admiral Bena, may he rest in peace, passed on later on in life, but his ideas stood. Of course, sadly, state fishing is no more. Now, I think the Navy has some 4 or 5 vessels. We used to have 25. So obviously, they benefited much more from it. So that was the essence of doing the tracer surveys. You definitely pick the few skills and the gaps from that. Now, I remember asking again now in my practice, I have a private practice here in Accra, and then one in Sinkor, Liberia. So I remember asking a coordinator who had brought students for training or attachment, how often do you get in touch? Very simple, benign question. Do you get in touch with your students? The answer was quite overwhelming in the sense that, when they come and visit, then we share with them. So how are you going to improve on your curriculum if you don't have a structured arrangement of getting in touch? Of course, these days probably because the output is huge, but you can still do some stratified analysis and get some information from these persons. So it is one thing that we can also do. The next is effective use of human resource. Let me make myself clear. I belong to the Association of Certified HRs. So if I bring it in, not that I'm being biased, but most of us don't seem to appreciate and understand the role that HR can play in this. And if you look, the principal constructs in human resource development include people, learning, and organizations. So all the things we want to talk about are really within the domain of our HR practitioners. So when we are doing any of these things, it becomes, shall I say, a bit suicidal when we leave them out of the picture, because they understand exactly what we're about. And I took the definition from one Garavan. In an article, he said, reclaiming the D in human resource development, a typology of development. And he defined HRD, and I can't forget his definition, as an unfolding process of growth that occurs in various ways along multiple trajectories at different levels of analysis, influenced by context and leading to a range of positive outcomes. All what we want in the theme is captured in this. So it tells you how powerful we can use our HRs, especially those in development. And these days, HR, we have the strategic HR as well, so it's important to understand. And these are all the knowledge that they impart, and everything we want to look out for in our students when they have come out is really captured in there. But we only think, if it's medicine, where, of course, I belong, I don't know so much about pharmacy, but if it's medicine, we go zooming in all the areas, etc., of diseases, blah, 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 blah. And then sometimes we forget the linkages that this may have in the industry. And I'll come to that and share a few experiences. So what linkages are we expected to use? Professional organizations. How often, for example, do we use, I don't know the pharmacy, but how often do we use the GMA to even maybe meet doctors in training and have discussion? They only meet, I must also admit, they only meet when the junior doctors are about graduating. We want to encourage them to come and join. That is not enough. They have a future, and we should start from where the future belongs. I remember in school when I was studying Latin, they said, non scholae decimus sed vita. We learn not for school, but for life. In our ancient days, you had to do Greek, Latin, French. Those were the 60s, so I still remember a few of them. The next one is to have invited guests. I remember going all the way to Naval Base sometimes, when I was then with State Fishing Corporation, obviously to share ideas within the industry with the officers at both naval bases. The Tema Naval Base, they were very close to us at that time, and then the Takrad Naval Base. And then, share ideas, give lectures, etc., etc. And then the next area is to use former industry colleagues. I'm sure you've produced a lot of people who are back in the industry. Use them. Let them talk to you. Let them talk to the students. I don't believe in this philosophy where you wait till the 5th year, then you are sending them out. A lot would have been lost. You needed to shape them up beneath you but not at this point in time. So it's important. And then obviously alumni or alumni connection, depending on which school you went, then you pronounce it that way. Yes. Those of us who went to the only school in Ghana, we know how to pronounce it. Yeah. Then good business must be ethical business. This is what sometimes most of our students forget, or perhaps we don't let them see the connect in this. In a classroom, you can do anything and get away with it. But in industry, a little bluff and you are in trouble. And so business must thrive in ethics. And graduates must be taught to appreciate that the legitimate aim of any business can and must be pursued in an ethically sensitive manner. If this is lost from beginning, he enters the organization and everything is in a different perspective. We'll come to this later on again. Mm-hmm. Now, I'm sure you teach them probably something on ethics, but please don't be too general, don't be too theoretical, and don't be impractical. Use basic things, very basic, connecting it to industry. And I'll give you a few examples. I remember for NHI going around teaching about health insurance and the necessity of keeping an accurate patient medical records, as we call it. And you meet a med soup and he gives you a folder, Tipex. He says, so we didn't have enough. So since this one hasn't been used for 3 years, we Tipex the name and put Mamma Mia. That is a legal document. Yet he doesn't understand what he's doing. Because he says he's run out of those ancient times. We're using these small folders, etc. So they Tipex it nicely and then write Adjoa Santoa's name, and then the patient is given to go ahead. That has huge legal implications. But there he says, med soup, I didn't have. So this is the only way probably he felt he could re-engineer or innovate to see his clients. But that was calamity. So I borrowed again example from the Federal Sentencing Guidelines, which later on perhaps we can share. There are 7 requirements, and it tells you exactly what you should do within industry so that when we now transpose this to our students, they are ready to appreciate when they come into the domain. I'm not going to run, so 7 of them. I've been told it's 20 minutes, so I need to keep to time. Yeah, so that is that. Now, the next point, academia scores high on hard skills, which are teachable. It's understandable. All these are good, but we forget this one, the soft skills. Again, I remember an incident that happened whilst vetting claims, and I had to call this colleague who had submitted claims to NHI. And I tried to explain a few things, and his card was before me, and I tried to explain to him a few things that he had done which were incorrect and not acceptable. But there he went, blurting, giddy, 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 giddy. I'm a professor of so and so, and I know what I need. Yes, you know what you need, but insurance is different. From the bottom, straight. Most of us don't appreciate some of these things. You may be a professor, I agree, but I told him the soft skill you have lost is that you don't even know who is on the other side of the telephone. And yet you go telling the person to shut up and listen to me because I am a professor of so and so. So when he finished, then I said, okay, Prof, it's good to know that you were born in 1981. Is that correct? He said, yes. That's my 3rd born. Yes. My 3rd born is a lawyer in the UK. She wouldn't talk this way. Enjoy your day. I'm stressing this for us to appreciate the soft skills that we lose. All these are there. And we need to impart this to them. Because with us, in industry, We are market-oriented. We are celebrating the customer this whole week. It's global. It tells you that we think that the customer is keen and will forever remain keen. And you cannot go to that customer telling all those kind of, shall I call them, niceties, because it won't pay. Yeah. Now, in industry, we understand and will continue to understand that by and large, the problems of industry are going to be solved by academia. No two ways about it. And I give an example from Tamaoya Refinery, where, when they produce the crude, it goes into what we call the CCS, the catalytic continuous system. Now, this system is supposed to run 24 hours. But at a point in time, it has to be shut because it accumulates so much that they have to drain and do all sorts of things. Industry now tells academia, and academia re-engineers, and now you can have a seamless flow, and they do it so beautifully. The problem is solved. Another problem was, I'm sure you've seen it, most often they will go and, when they load the crude, they will go and climb and do a dip to check the quantity, of course, and the weight. You have a good driver who wants to make money on the side, loads heavy items on it, and it adds to the weight. So you've dipped, you've checked, you've gone. Obey the rest, and it's simple business. So they tell academia they are losing there, and academia now designs, and they can sit in the comfort of their room and program and see it. So we understand and we appreciate that there's that link with academia we can never forget. The two of us must fuse together. This notwithstanding, both sides must appreciate the vision of each other. Researchers are motivated by science. That's obvious. We are motivated by the markets. But we should understand how we can blend the two together. The two together. Because if you don't apply the sciences, we'll still be wallowing in the darkness because we need you. Now, one thorny issue is the issue of budget, because research demands that there should be money made available. And the whole African continent, unfortunately, we have failed to implement our Abuja Declaration, which was done some 2001, thereabout. We're all supposed to set aside 15% of our budget for health and research. As we speak now, the only country that came close to it and attained it is South Africa. Nobody has done it. Ghana, we are nowhere near. So we need to find an area where we can get a resource, the funding, to be able to do that. And that is how come we think industry must appreciate this dilemma and forge a relationship with academia. Unfortunately, there are a few barriers that seem to. Let me summarize a sentiment from one of the players. I just asked this when I was coming to make the presentation. And so I'm quoting, it says, industry partners stated in no uncertain terms that they would feel more valued if they were frequently consulted. I don't know. This is a player saying that. Being valued is actually listening to what we want, in contrast to an approach that rambles on and ends with a statement, oh, and so you should fund my project. That is the way he looked at it. Whether that is representative of everybody, I don't know. But at least I got this from an industry player. So it tells you that, yes, we need to appreciate each other. We need to understand that, yes, together we can move on. Now, there's one area that also affects the discussion and the communication. That is intellectual property. And as a student of law, I also had to quote this from our Patent Act. You see, unfortunately, most things within the realm of medicine cannot be patented. And this is what the Act says. It says, matters excluded from patent protection Subsection C says, methods for treatment of the human or animal body by surgery or therapy, as well as diagnostic methods, practice of the human or animal body are excluded. So discuss and communicate this effectively amongst yourselves. Otherwise, the person thinks that I'm funding, I expect that when it is done, the product will be named maybe Professor Jare and Echo Morrison, something like that. But it shouldn't be, and it may not be necessary. So that at least there's a clear intention beneath you so that we don't get. So this has been a tricky area because one person mentioned that, yes, I funded somebody and blah, 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 blah. Then I explained to him that this is the situation. Oh, but why didn't he tell me? Is it that perhaps he also didn't know, but at least this is a knowledge sharing avenue, and so we need to get this clear. And then sponsor and teach soft skills, team building, project and project management. By getting involved with team building and development, industry will be providing students with the interpersonal and transferable skills that industry and community needs. And these are some of the skills that we've talked about earlier on. So it's up to us in industry, now that we recognize that our products come in there lacking in this, let's devote some of our corporate social responsibilities to making sure that we go into academia and say we want to offer these models and train the people. Maybe academia may not have the time, but once we do this, we should be able to. We shouldn't always do corporate social responsibility by building bus stops and voting for party activities. It won't help anybody. Yes. So in conclusion, for our health colleges, I will leave you with a mantra. The Kaizen principle works everywhere. It doesn't only in industry, because it's based, Kaizen principle is used by Toyota, and it's about your life. Life wherever you are, at home, at work, at school, no matter where you are supposed to have a continuous improvement in that life, irrespective. So if you have this as your mantra, then you appreciate that, yes, this is what I have to do. That is the Kaizen principle. Let's all keep that principle, as I've just said. And then the next thing I often say, you cannot manage what you cannot measure or you don't measure. So everything that you want to manage, make sure you have the indicators and be able to measure them. And on that note, I say thank you so much.
In this 30 minutes, I think we've gone to the classroom, we've gone into industry, and I dare say we have to examine how best academia can truly speak to industry's problems. Thank you so much. I was almost about to say thank you so much, Professor Morrison. Okay, so we definitely will have a very exciting time this morning. So we'll move on. Our next speaker is Dr. Paul Sechere Nyantakyi. Dr. Nyantakyi is also a physician entrepreneur with over 20 years experience in the medical profession, having worked both in the United States and in Ghana. His passion for evidence-based medicine has driven him to spend most of his professional life in medical diagnostics and medical research, and now moving towards clinical trials. His work has transformed laboratory medicine in Ghana over the past 20 years. Dr. Nyantakyi is a graduate of the Johns Hopkins School of Medicine in Baltimore, Maryland, in the USA, with a Doctor of Medicine degree, and interned also at the Yale Medical School. He was conferred an honorary doctorate of science degree by his undergraduate alma mater in Virginia, in the United States, in 2014. He also holds a certificate from the Executive Program on Good Corporate Governance in Ghana at the Ghana Institute of Management and Public Administration, GIMPA. Most importantly, and how close he comes to us, he's the founder of and chief executive of MDS Lancet Laboratories, which we all know, and now Quest Medical Imaging. The companies provide medical diagnostics and preventive services to both private and the public health services. Under his visionary leadership, Dr. Nyantechi has led MDS Lancet to win several awards for the company's contribution to healthcare delivery in Ghana. He's also a recipient of the Johns Hopkins School of Medicine prestigious Global Achievement Award. Lastly, he's a recipient of many individual and company awards, and most current is the Outstanding CEO of the Year, Ghana Medical Diagnostic Excellence Award in August 2023, so just about 2 months ago, at the 13th edition. Ladies and gentlemen, please help me welcome Dr. Paul Setre Nyantechi.
Good morning, Pro-Vice. Please permit me to associate myself with the protocols already established. When I was asked to do this, I was wondering whether I would be the right person, because normally I'm a very shy person. I'm very comfortable when I'm at Lancet. But I look at it and I realize, okay, it's academia, so normally in classrooms you are safe. So I'm going to try to approach this from my experience, because when I look at the topic for discussion, I was asking myself what to do. But fortunately, I've had the opportunity to be working with all the professionals across the medical health delivery, from medical doctors, radiographers, sonographers, medical lab scientists, nurses, across board for the last 20 years. And there's something I've observed, which until I met Professor Deborah, probably it wouldn't come out like this. I have established a training program within Lancet that I was going to address those things. So I'm going to be touching on some sensitive points, but I guess that is what academia is all about. I'm going to have to be skipping a lot of the things. So the background I just mentioned, and I will move on quickly because of lack of time to some of the observations. So disclaimer here is all these things are my observations and perceptions. It can be false or it can be true, but that will be done tomorrow and probably this morning. So I'm not here to say anything on authority. They are all observations. So in case I don't have 20/20 vision, that becomes a problem. The first thing I noticed when I came back as a certified internist, normally the tradition is you come and open a hospital and you practice. But I can say for a fact that about 23 years ago, we were still using calorimeters to measure HB. That is what actually moved me away. And I was coming from that time, having the privilege to be at Hopkins. Evidence medicine was starting. So I couldn't imagine how I was going to practice my own hospital or clinic. So that was the whole idea of me now shifting to this. And quickly I realized that teamwork was a problem, because I was coming from an environment that when we do morning rounds in the teaching hospitals, it's a team. Starting with the doctors, pharmacy will be part, medical lab scientists, social workers, psychiatrists, everybody is there for a holistic management of the patient. And here I find out was extremely lacking, but we all know the importance of teamwork. And I really hate to use those words, but again, from observation, I felt the teamwork was really fractured. And for me, healthcare was everything. Growing up, I couldn't do anything apart from healthcare. And if there's any profession that needs teamwork, I can overemphasize that it has to be healthcare, because of the important role that each of the healthcare professionals play. So this is a profession where you allow ego to come in, we are all dead. We can be patient at any time. But that was what is happening. The mentality, I thought, then starts from the training, as we're going to be talking about the gaps. These are some of the things I've heard and witnessed during my interactions with my staff. And currently I have about 450 staff across the country, consisting of doctors, medical lab scientists, radiographers, and sonographers. And you hear things like, without us, doctors cannot make diagnosis or work. And then when you come to the fifth one, the doctors that I talked to also, okay, if we lay down our tools, no hospital can function in Ghana. And it keeps going on. So the question comes in, what are you going to do with the teamwork? For me, what I've been training the staff at Lancet is for them to understand, first of all, why we even get the request form. So it's not about a doctor or anything, but at least every institution must have somebody leading it. That is why we have to beg for or observe the courtesy from provost to allow us to be here this morning. So I think this is linked to the ethical training Dr. Morrison mentioned. If we can get students right at the right time to understand that healthcare is not about competition. It's about being proud of the role you play to put together and make the puzzle at the end of the day is for the holistic taking care of the patient. Then I think we're going to make it. But the gap I see is there because everybody is claiming the importance and the dominance. But the reality is, if the doctors are going to lead the healthcare, then they're going to take a good history. They're going to come up with some differential diagnosis, do physical examination, and come back and say, okay, now I need to pick a diagnostic test, whether it's imaging or pathology, to rule out or to confirm my diagnosis. Now, if that is the case, it comes down to communication that we need to have for us to appreciate, because as a doctor, if I'm going to come up with a request form, how do I select the test? So I want to challenge the medical faculty here that I have seen request forms from my colleagues that are not correct. Okay? And then what happens? Because of the first points I've mentioned, that everybody is claiming dominance, then the medical lab scientists will go like, look at the request form. The doctor is asking for Hep C antigen. Well, unless you want to do viral load. Otherwise, in the market, you do antigen for Hep B, but Hep C is antibody. And so these are little things that would fuel the antagonism that is there, and then it keeps going. But if we identify and share the information from what we observe, at least what I have seen, then we are going to see how we're going to support the training and bring it together. So the communication is so critical because doctors don't want to write anything on the request form about clinical history. I have inquired that from some colleagues. Oh no, the moment you say you are suspecting malaria, they're going to give you malaria parasite 2+. Again, my question is, Dr. Morris, in the ethical training, if a doctor can't trust that medical lab scientists are professionals, well-trained, disciplined, and that nobody is going to write 2+ when they can observe it, then there is a problem. There's a real problem. So in the process, there is no clinical information on the request form. So you keep repeating the test, increasing cost, which eventually adds to the healthcare cost. See, so I would like for us to look at the ethical training for all healthcare professionals to understand the responsibility that we have, that we are dealing with people's life, health. And if you don't see it, we are not going to put 1+ or 2+. But then comes the whole big picture if we all understand and have been taught well. The question is, are you going to always see malaria parasite before you confirm that you have malaria? I'm sure the professors here know. The answer is no. It's not all the time. So the communication, the written, verbal, sometimes I have seen request forms that people will put retro test instead of, say, HIV. They say they don't want people to see. But the last time I checked, retro is not really like an official name for any test, you know, and it's a problem. So tomorrow, I think we will have time to discuss more about these gaps. Now, this is some of the things. Doctors are not filling their prescriptions and laboratory and imaging request forms well. In Ghana, doctors will send people to lab just to do HVS, for instance, and they have not explained to the patient. So the lab scientists will go in and try to get the patient to lie down for samples to be taken, and it becomes a problem. So that, I don't know what is going on there. Well, the question of contact telephone numbers, as I said, they are observations. I'm putting them here because in our healthcare system, we are depending on a lab which is outpatient basis. And sometimes you're going to get some panic results. And ideally, you wish you have to communicate to the doctor, and you can't. There's a big one there is the poor communication between doctors and all the other health staff, leading to the misinterpretation of instructions and results. And it's all because, I think, again, the ego thing comes in. The effect of poor communication, obviously, there's only one person that suffers here, is the patient. And because any one of us here can be a patient at any time, then you need to think about it. So some of the suggestions is that we're going to have to begin to get the culture right from the training level. That we need clinical information fully spelled out on request forms to ensure correct tests are performed, especially in radiology. Some doctors can request for MRI, but in reality, the golden test for that particular, if you really have full clinical history, would have been CT scan. And sometimes just a simple ultrasound may be the first line of a procedure you should do. And if you look at the cost of ultrasound, maximum up to 500 Ghana cedis, and MRI at the upper limit of 2005. In a country that we pay for health services, you can see what we are doing to our patients. So if you don't get the right communication, the ethical training to trust and do these things, these are few problems that we face. The communication can touch on, we are in an era of information technology, and I'm hoping that we can find a way to introduce, because currently, you're not going to get any health professional coming out and say that they are technology, IT challenged. It's going to be a problem, and it happens now. I will encourage that medical doctors, my colleagues, should learn to respect other healthcare workers enough. It's critical, because we are talking about clinical literature that says that 70% of clinicians' decisions are based on medical diagnostics. So this is the caveat. How can you decide that and then you don't respect the people that will do the test for you? You see, I always find it very difficult. It's the same way we have been treating our teachers. Without them, we wouldn't be where we are. But then we don't pay them well, we don't do anything to them, and that kind of thing. And we are seeing that also here. In this current era also, there's a data protection, patients' rights, and everything. And we need to sensitize our students before they get out to have that great respect for it. Now, this part is so critical because I have been a victim of it, where my colleagues treat lab results instead of treating the patient. And again, it's something we need to emphasize. As I said, every medical school is teaching doctors the importance of good history. You have to take good history to get to make any differential diagnosis. So you're going to have situations where your clinical suspicion will not get you the results that you requested for. But if you're going to just treat, because I've given you D-dimer and you want to treat for PE, this is where my observations. Let us make sure all the healthcare professionals understand that in diagnostics, the laboratory tests, each one of them has sensitivity and specificity. And most colleagues don't know that. So if you're going to treat somebody for PE based on D-dimer results without clinical symptoms, and then when you kill the patient, then you want to hold the lab responsible. And then who is in charge of healthcare? Doctors not saying they are in charge, or they are only in charge when it comes to money. So, again, with all due respect, I said they are observations and perceptions. They can be false or right. So these are the things I was talking about. 70% of our medical diagnoses are based on laboratory imaging investigations. So we need to pay attention to the training we are giving to all the allied health students, because this is the feed that we're going to get. Now, there are always going to be incidental finding. There are some colleagues, when they are suspecting malaria, that's it. The moment you give them any other results, they are not going to ignore it. Just jump to the next lab and tell the lab, I was suspecting malaria. And they say no parasite. Okay, the next lab will definitely give you 2 pluses. Because you are imposing, you are forcing them to tell you that, give me malaria results so I can treat. So I just put it there. How are you going to treat incidental findings, especially in imaging, especially in radiology? And again, comes back to the communication. If we don't establish from the beginning good training, how health professionals are going to communicate, then some of these things are going to be ignored and until it's too late. I had to pray to God to touch on this one, and then probably I will leave. I have a serious problem about enrollment process, and I call it the medical school problem. In US, where I had my education, the people that want to do lab shown interest, and it's not about their grades, and they pursue it because they understand the role they play in healthcare, and they are receive that respect also. In Ghana, it's a fact. You see how I'm hesitating, Provost, to say. Even when we were in high school, we think all the science students are brilliant. Okay, if you continue like that and now we can get people to rule us, whose fault? So this perception starts right there. And we keep admitting all A students to medical school. And from my experience, the straight A's tend to be very bad practitioners of medicine because of lack of emotional intelligence. And if we continue to do that, and we make it look like it's a substitution enrollment, oh, I wanted to go to medical school because I couldn't get it. Now I'm coming to do lab. Please, it leaves a psychological something. You are all healthcare persons, so I don't have a theory here. But we should know. And it continues, and then it comes onto the floor to a point that it becomes so difficult for aligned health professionals to sometimes even communicate with the doctors. I don't know whether it's intimidation, whether it's ego or what, but I wish something would be done when it comes to the admission. That it shouldn't be that people that do aligned health were medical or suicide. And it creates so much problem. I wish we would get our best, because I have witnessed, and it's not because I'm at KNUST. Professor Deborah came for the talk. He saw alumni from KNUST. And some of my best staff are products from this institution. Okay, so I've seen brilliant, and as I sit, I have one here who is a Kumasi branch manager and has done very well. So again, it is not true that if you don't go to medical school, it means you are not smart. No. But it's causing too much harm for the unity and the team spirit that we are talking about. So that is all I have said. It's not true that all the brilliant minds should go. Yes, you can get A. The fact that you are getting A doesn't mean you are, or in other words, experience have shown that you don't have to be an A student to be the best doctor. Medicine is holistic, and the research shows the way human beings feel, more than 50% is psychosocial anyway. So if you don't get speciality and bring in all the liberal arts and humanities and teach people to have compassion, we are producing robots. So suggestions here are basically we have to encourage interdisciplinary training from the universities. We have to encourage joint lectures. I'm told it happens. The question is, do we make conscious effort to let the students understand that we are not just doing joint lectures just to let you know you can all compete. We have to encourage joint research projects that doctors and all the healthcare professionals are mixed up so the exchange of ideas will come. And we have to make sure there's equal distribution of excellent students across all program areas, if it's possible. But the last one is important because you see, we two or something like that. These things can be theory suggestions, but whoever is responsible, equal opportunities and competitive salaries across all professional areas must also be established so that we can achieve all-round healthy health professionals. So thank you very much.
We shouldn't fracture communication. I think that was the highlight of my learning this morning. It's so effective. And I was trying to think about maybe we should go back to ground rounds. When I was a medical student, when I was a house officer, I know at least there was ground rounds. Maybe when we get to curriculum, we'll see whether we need to go back to that. So we are good on time. And therefore, we want to take a third presentation before we go for the snack break. We don't want to break the flow in the learning process. So our third presentation would also be delivered by, so now we've moved from industry and we are going to look at the tool we are using in teaching. How good, how excellent is it, and what should change or what should be maintained? So our third presentation is on curriculum innovation, practical steps to design a curriculum that responds to modern trends and ensures adequate practical training for graduates. And that is going to be presented by Professor Richard Adanu. Professor Adanu is currently director of the Ghana College of Physicians and Surgeons. He's been rector since February 2021. Professor Adanu is a consultant obstetrician gynecologist and women's reproductive health epidemiologist. In addition to being a fellow of the Ghana College of Physicians and Surgeons, he's also a fellow of the West African College of Surgeons and an honorary fellow of the American College of Obstetricians and Gynecologists. He graduated from the University of Ghana Medical School and completed his postgraduate training in obstetrics and gynecology at the Kolebu Teaching Hospital in Accra. He later obtained a Master of Public Health degree from the Johns Hopkins Bloomberg School of Public Health as a Gates Scholar and was admitted into the Delta Omega Public Health Honor Society. Professor Adanu has extensive experience in the field of maternal mortality and morbidity reduction, contraceptive use by women, and cervical cancer screening, and has served locally and internationally as a consultant in these areas. I want to jump a little bit so that, because it's, we have very excellent health professionals in our midst. So if you profile them, you could speak forever, but I'm not giving the presentation. So just permit me to skip to the last paragraph. He's also a very leading researcher, and his interests in research are in epidemiology of obstetric and gynecological disorders in Ghana, family planning, cervical cancer screening, and maternal injuries. Some of his previous international responsibilities include leading a consortium of 11 African universities to facilitate an educational mobility program funded by the European Union, and serving as an external consultant for the Research Capacity Strengthening, Reproductive Health and Research Department, WHO Geneva. Professor Adanu has published widely in the field of obstetrics and gynecology and women's health, with over 120 peer-reviewed publications and several editorial publications, as well as chapters in books and technical reports. So we want to once again welcome Professor Richard Adanu to give us his presentation.
Well, good morning, everyone. And just like the other speakers have done, I would assume all the protocols that have been defined. And I'll start off by saying that KNUST is doing something that I think is hard for some universities like mine to do. I mean, you organize programs like this, and the attendance is really great. I mean, maybe there's some money that's being paid that we are not aware of. But I think this is very, very impressive. Right, so for this presentation, I'll be focusing on the need to collaborate with industry when designing our curricula, and then also practical steps that we need to follow. I mean, when we are developing the curriculum that responds to trends. And the first two speakers have highlighted some of the things that they've seen as the gaps that our products display when they get into industry. And to be helpful if we note all these things, because these are the things that will then feed into the curriculum that we develop and help produce people who are more useful when they step out. So this is what I'm going to be speaking about. I would run through these different parts. So we all know our products. We all know our products. They are varied. When you take a College of Health Sciences, the products are varied. So it's difficult to talk about one thing that matches every single product. But then there are some common things, and I'll try to point out some of those common things as I go along. But the truth is that each of us, as we train, need to be familiar with who our products are and where those products are going to end up. And that should guide the curriculum that we develop. And with our products to make it even more complicated, that there are different levels. There are those who come out as the undergrads, those who come out with master degrees, and those who go on and have the PhDs. And the way these different people function in industry is also different. So certain things that we need to emphasize with the undergraduates might not be that important with the people who are doing PhDs. And sometimes we act as if the PhD is advanced compared to the master degree. But I think of them as different degrees. Because in the industry, what they expect the person with a master degree to do is different from what they expect the person with a PhD to do. And our industry partners will tell us that sometimes some people, come to their place with PhDs, and really, they've forgotten the skills that are needed at the master level, which is what they really need to deliver at industry. So career counseling is also important. Not everybody needs to do a PhD. Doing a PhD doesn't necessarily give you an advantage in one field, compared to the other. So these are the kind of things that happen. The people who come out of our programs, the undergrads generally serve as low to middle level staff. And as university education is kind of like proliferating in the country, I mean, undergrads, I'll digress here. My daughter did a house job with the police hospital. And when she finished the house job, she didn't fear the policemen on the street anymore. She said, well, these ones, they are just SS graduates. I mean, the degree ones sit in the office. But as the universities proliferate, some degree ones are going to be on the streets, you know. So undergraduate is for low to middle level staff. And then when it comes to the master degree, they tend to function as middle level staff to managers, the head of units. They are the ones who drive things. And many people in the industry don't even want these people to go on and do PhDs. They still don't need them to go and do PhDs. Because when you get a PhD, essentially you're functioning as an academic or a researcher. And sometimes that's not what is needed in the industry. So if we want to develop curricula that meet the needs of industry, these are some crucial questions that we need to answer if we really want to partner with industry. I mean, the people that you are turning out, who is their largest employer? Because the largest employer, what that largest employer needs has to be in everybody. If there's somebody who employs, say, about 90% of your graduates, you need to know what that person's needs are and make sure that all the people there get it. When you think of something like the medical school, some of our people graduate and they go to a hospital and they are given a guideline of practice designed by Ghana Health Service, which they have never seen before. They have never seen before because we don't work that into our training. I mean, they are conversant with all the big current latest edition European textbooks, but they haven't seen the guideline. They don't even know about the essential drug list because we just don't bring that out there. And then we should find out which of the employers across the field has the highest standards. That's also very important. Because if you know that one, you must make sure that your graduates can match those standards also. Because sometimes some people come out and say that even our first class, graduates are not able to function when they get into their company. Maybe because we lost sight of what is the standards of which of our industry partners has the highest standards. We need to identify that, and it's easy to find that out. It may not be one company, maybe a group of companies. Then, what does the industry expect of our people? Now, as we talk about partnerships, not only the industry, the general public also. I mean, like when Dr. Yentichi was speaking, he said, when there's bad communication, there's a patient that suffers. So if you think only about what the laboratory or the pharmaceutical industry expects of your graduates, you forget what the clients expect. Then we don't teach those kind of like soft skills, where sometimes the person walks into your consulting room and all you need to do is to make eye contact while the person talks. And after the person has talked and talked, the person begins to feel better. It's just that eye contact, that's all. But if you are busy, I mean, your eyes are roaming everywhere and then you write the best prescription, the person walks out still feeling, I wasn't really listened to. I wonder whether this thing would work. And the person might not even go and pick it. So what does the general public expect? Then what does government also expect? Because they're going to go out to serve government. Then the global industry. We are training people not only for Ghana. Beyond Ghana, what do they expect? One of the things that I've noticed over the years with our products, and I train mainly medical students and public health people, so that's the reference I would make. We have, when it comes to like medicine, especially the surgical fields, we end up producing very great technicians. These are the postgraduate level. We have people who, they are very skillful. They can perform almost any surgery. But these people haven't been trained to be able to talk. You understand? I mean, when it gets into why do you do this, they kind of stammer. So these are great people who are the best to treat the people, but when you take them out and go to an international conference, they are so quiet. They are so quiet. They don't kind of talk with the other people, and they sit back. And the people who are talking, who know all the theory, many of them are very suspect when it comes to the skills. So we need to know what's expected by the global industry and then also put that in our people. So to answer these questions, we need active engagement in local industry. Then we also need, we the teachers need to engage with local industry, and we the teachers also need to be exposed to the global industry. I mean, we cannot teach and make our people ready for the global industry when all we do is engage in the local one. So maybe we don't even talk with the local industrial players. Then we must know what the government policies are for our products. I mean, nurses are coming out, pharmacists are coming out. I mean, what are the government policies that are coming out concerning these people? And we must prepare them to be able to work within the scope of those government policies. We as teachers, we as an institution, we as a college need to have close relationship with the leaders in industry. And it's great that we're doing this out here. Then we must know what are the changes going on, the modern changes going on in the field. See, as you think of these things, you realize that being a university lecturer is a difficult job. It's a real challenging job. In a sense, you are in the ivory tower, but then you need to know everything that is out there so that your products can go out there and meet it. So there's a lot that we need to do. So what things can help us get into this? One is working in the industry. We've got to find a way by which it is legal for people who teach in the university to also work in the industry. And nobody will say things about drawing two salaries or things like that. We have to find a way. I mean, because if you are not in, it's hard for you to say what people are doing. And sometimes some of us are in, but we are in kind of doing what you call locum. And then you go to a place where, for instance, you are doing a locum at Lancet. And Lancet has the top machines for the investigations happening there. Now you are training your students at Confanochi or Kolebu, where those machines are not there. And you can't find a way of marrying your locum life with your day job. Because maybe somebody found out that you are taking your students to Lancet to show them things. I mean, you might not get promoted. So then you turn out products who are first class, who haven't seen certain machines that are in the country. They are not abroad, they are in the country. So we have to find a way of doing that. Another way useful practice is for us in the universities providing consultancy services for industry and making sure that those consultancy services that we do find their way into our training and how we teach. Conferences, very important, very important, even if it means putting your own money aside so that you can go to that conference. Do it. I mean, it's like the investor is giving money, so I'll go for a conference. Okay, you sit there, and your students will always come out and kind of be like, oh, you are the one who doesn't teach them well. And these days, the students are smart too. They kind of have access to the whole global thing. You know, and like Dr. Nyantichi said, we get the A's are all in the health sciences. Don't tell the other colleges that I said that. They are all in the health sciences. And they walk into your class after the first lecture. Well, this guy is not on top of it. They go online. They get that same course from Yale. And then the smart ones don't come to your class again. And there are so many that you don't even know. At the end, you say, oh, my students got A's. And you pat yourself on the back that I'm a good teacher. And they are going away saying that, oh, this bad teacher. I mean, they basically took the Yale course and came and passed your thing. So attending conferences with practitioners and knowing and the knowledge produced is important. Then we must have dialogue with the industry players. So these are some of the good things that we need to do. So as we are doing these things, then we come to the curriculum, which is what we do. So what's a curriculum? So you can think of a curriculum in different ways. One way is to say that the curriculum for this particular course is these different subjects that people have to take. So that is the big bird's overview of it. That if you're doing, say, medicine, you must take these courses. If you're doing physiotherapy, you must take these courses. That's a big bird's eye view of it. Then it comes down to like, when you take a single course, then you are looking at the experiences that the students must have, the lectures that they must have, the attachments that they must have, the things that give them the skill. And this is very essential. All of us need to come to terms with it. I mean, I'm not actively teaching in the medical school these days, but if I look back to when I was in the medical school, some of us didn't even have an idea that something like curriculum existed. Because, I mean, there was something on the notice board, and there are these lectures, and these are lectures that you have to give, and the students would come to you as to how they came up with that list of lectures. I mean, you didn't even know. You went and gave your 4 lectures, and then you took the students on the ward. And you've never really been involved in the whole curriculum design process. And I'll talk some more about that as we go along. Now, these are the let me say, the main elements of a curriculum. It may change as you may add things, but these ones must not be missed out. The objectives. What do you intend to achieve at the end of the course? I mean, 5, 10 things that at the end of the course, everybody must have got these things, or you must have achieved these things. Then we come to what is the content. So if this is what we want to achieve, what must be the content? What are the lectures we must give? What are the attachments they must do? What are the practical sessions they must have? That's the content. Then it doesn't end with that. How do we deliver the content? How do we deliver the content? And many of us, how do we deliver the content? There's only one answer: we'll give lectures. I mean, 13 weeks. We'll give 13 lectures and we are done. If we can do it in 6 weeks, Christ, good. You understand? And the students are so bad. I mean, they don't complain that this thing that's meant to be for 13 weeks, you just taught it in 6 weeks. And they take the free time and they are gone. You know, but if really something is 13 weeks and you teach it in 6 weeks, you're not doing a good job. So how do we deliver? It's not only lectures. We'll talk some more about that. Then how do we assess the students? And all these things are not secrets. They must be known to the students. It's shared with them, and they know what to expect, and they are ticking the boxes as they go along, and know that actual objectives 6 and 7 were not achieved. So who designs the curriculum? There are different people. We could take it that a single lecturer, so a lecturer who's given this course to teach, you're supposed to teach maybe like biological basis of public health. Then you sit down and you come out with a curriculum, keeping in mind these main things that we've said. Or it could be a group of lecturers. 2, 3, 4, 5 lecturers come together and they design, because maybe they are co-teaching the course. Or it could be the head of department. Like what I said about when I was in medical school teaching, probably the head of department had sat down and come out with those different things, and the content were those lectures. And said, I don't know, teach lectures 6, 10, and 12. And I just went and taught those ones. Then there's a role for all lecturers of the department. How does this happen? So, see, curriculum development is best when done by a team of lecturers from the department. So a group of people come together, and then they sit down and design the curriculum. That's when you probably get the best curriculum. You see, there was somebody who told me that like in their journal, when they get a paper that is single authored, and if it is not just a case report, they don't even read it. They just reject. You get immediate reject letter. They don't bother reading it, because their thinking is that knowledge has spread so much that no one person can write a good paper on a deep subject. So if it's one paper by Adanu and he's saying that he's talking about the political, social determinants of this and this in Ghana, it's like, no, we know Ghanaians. There are a number of intelligent Ghanaians around. Reject. So a group of lecturers coming together is important. Now, all the lecturers in the department need to come together to agree on departmental ground rules for single courses. Before you go and design your curriculum on biological basis of public health, you must know the departmental rules, which have been agreed by the whole department, that you must teach for 13 weeks, it must involve lectures, practical attachment, this, that. So the department has set the ground rules, and then you move. So the collective wisdom is helping. Then, even within the school, that's where the dean leads. And there are ground rules for curriculum. So the ground rules for curriculum are coming. So there's a level which is at the dean's office, a level which is at the head of department's office, then a level that comes down to the individual lecturers. If we don't do this, our curricula are definitely not good, and they are definitely not meeting the needs of industry. So, effective curriculum, it adapts to the evolving world. I've put that in bold because that's what we are talking about with this engagement with industry. Curricula need to be revised as things change, as industry change. I mean, what you put in, how you deliver it must change. I mean, there was some time when some colleagues of mine were complaining that we're trying to develop videos that teach people how to do clinical examinations. We actually came out with some of those which are being used still. I mean, it was a collaboration. There's some that even came from KNUST and then UG. So we're developing these videos, and some people's problem was that if you develop these videos and the students can learn how to do clinical examinations from them, then they won't come to class. My response was that, well, if all you do in the class is a repetition of that video, if I were your student, I won't come. When I was in school, and this is, I'm going dangerous territory now. I mean, I basically didn't go to a class if I thought it was a total waste of my time. I didn't go. Because, hey, I could get it in like 15 minutes by reading this thing here. And the guy is just going to come and read the same thing in the book out there. Why should I go? And the students today are sharper than I am. What they don't, basically, it's the exact principle. I'm sure Dr. Jan Tichi and Dr. Morrison will agree. See, what you can get for free, don't pay for. That's the business world. So what you can get in 20 minutes, don't sit in a class for an hour for. You've wasted 40 minutes of your life. You could spend those 40 minutes doing something else. So the thing is that you must make sure that the aids are out there, but if the person doesn't come to the class and engage with you and get that additional thing, there's no way he or she is going to pass. And once they are aware of that, well, they'll come to the class. They'll come to the class. So it adapts to the evolving world. And there should be research-based teaching techniques. It should encourage collaboration. We talked about teamwork earlier on. You can teach teamwork in how you deliver the course. And it meets the needs of the students. When it doesn't meet their need, don't come to the class. It must engage them and their objectives that you are seeking to achieve. Then it must meet the school's core values. If something like honesty and integrity is a school's core value, there must be a way in which in every single course that is taught, there's something that drives honesty and integrity. So you can say that when people graduate from this school, they've learned the basics of ethics. Because teaching a course on ethics is different from getting ethics into people. You work it into the course and then it goes. I've got to move fast here. So how do we develop a curriculum? The practical steps. These are 5 steps that are put down here. There's familiarization, there's consultation, there's drafting, there's reviewing, and there's finalization. These are kind of like, they're my things. I mean, it's not picked from somewhere. This is how I think about curriculum development. What's familiarization? First, you stop and ask yourself, what were you taught? And how were you taught? See, that question is important because unless you graduated yesterday, when you ask this question, it will tell you that I must go beyond what and how I was taught because the world has moved on. If all you do is that you take the way you were taught, the course content, and come and deliver it, you were taught 20 years ago and deliver that same thing, definitely not useful, definitely not challenging. Then, how is the subject or course being taught now? So you go online. This is going to go far. You go online. You talk to friends who are in other universities. I'm teaching this particular course. Do you have something that's similar in your university? How is it taught? And let them send material to you. You can get material from online. And then when you get those materials from online, it helps you identify curricula that are used as benchmarking. If this is how Hopkins is doing it, okay, we'll make sure that we are kind of like at that level. That's a global thing that we're talking about. And then make a field trip. The people who are employing your students, this is all familiarization. You've not started writing yet. Go to the places where your students are employed and see what is demanded. Meet with the CEOs, meet with the team heads. That is all familiarization. And after you've educated yourself, then we come to consultation. Discuss with leaders in the local and global industry. This is where the largest employer thing comes in. Get somebody from the largest employer or two people from there, talk with them. Get one or two people from the employer with the highest standards, talk with them. Then talk with other teachers. Senior ones, junior ones, older ones, younger ones. And this discussion must cover these 4 elements. So that when you, objectives, we've talked about that, we've talked about all these things. But you must have this discussion with all these people. With all these people, get their input. Then you now sit down and draft. So now you write out the curriculum along the lines of the main elements based on your input from these people and also the lines along which regulatory agencies want things to be done. Regulatory agency might not have all these things that I'm saying, but you have the regulatory agency one, then you have your expanded curriculum that has all the other things that we are talking about. Then reviewing. You now give your draft to the people who took part in the consultation. These people. I mean, each of them must see the draft. Each of them must see the draft, and then they make input. Each of them sees the draft and they make input, and then they check the curriculum for relevance. Then you incorporate their comments and you come out with the final thing. And if we go through these steps, we might not have an excellent curriculum, but we'll have one that is useful, and that helps people better than if we didn't go through that process. So, these are some final thoughts. I mean, think again about the methods. We said the curriculum must include methods, isn't it? Lectures, generally overused. Generally overused. Too much of lectures. But there are things like industry exposure, individual assignments, group work, getting them to watch some videos or do some observation, group discussions, practical sessions. Our methods must be a mix of these. A mix. There doesn't have to be a lecture every single class that we do. Then let's think again about evaluation. Write for 3 hours, timed final exam. And it's like we act as if that is the way to assess people. But it probably doesn't work. And we've been doing that from kindergarten. And university too, we are still doing it. And we are still even covering the answers as we are writing so nobody can see. I mean, fixed time exam is probably overused. I think it's overused. I think it's overused. And we have to ask ourselves, essays, overused and sometimes poorly said. Adanu is a man, discuss. Okay. Okay, how do we discuss that one? You know, those kind of things. A statement is put there, then they put at the end, discuss. And we think that's a good essay. So, multiple choice questions. We are using them, but probably not using them to the widest range that we can. Because I'm told that multiple choice questions can actually test a wide range of things. But sometimes we set multiple choice questions that are just testing recall, and that doesn't help. Take-home exams. You see, if you're going to say take-home, if you say that you assess your people by take-home exams, then it's a thing that they've taken home and it really engages them. If many of us here review things and they give you 2 weeks, but then it's kind of like you do it in like 3 hours. You understand? So really the 2 weeks is actually too much time. So sometimes I get the things, get this, and sometimes I forget. Prophet Jerry is here. He knows that sometimes I forget. I get the thing, I know that this I can do it in 2 days. Then I forget. Then I get the phone call. Oh, Prof, the promotion review. I say, yeah, I forgot this thing. But because I told myself that this I can actually do it in 2 days. So, but when you give your students exams, don't give them 2 weeks if the thing can be done in 2 days. Give them 2 days, and at the end, they know that they've really worked. They've really worked. Then you can give a mark for that. Projects. Industry problem simulations. Things that are out in the industry, and what do they do? These are things that we should think about. Important industrial skills. You see the ones that are in bold. Taking minutes, producing meeting reports, making presentations, leading a discussion and drawing conclusion, researching a question and presenting an unplagiarized summary report at short notice. This is what bosses want. The boss walks in. You know what? I hear there's a new treatment for this condition. I want you to find out about it and give me a write-up and get you on my desk in an hour. And they do it. You see, you should want to do that to our students. Walk into class and say, okay, it's a 2-hour class, isn't it? So there's this problem. Research on it, write a report, and the report is what you submit, printed at the end of this class, 2 hours, and you walk out. Yes, and you can walk out and play a video game during that time, but they'll have to come out with that. That is what happens in the workplace. And nobody will tell you that, well, I saw your students out there, are supposed to be teaching at this time. I'm teaching. It's like, no, you are not in class. Well, I don't need to be in class to teach. I'm teaching. And when they bring it at night, when I'm marking what they've done, where will you be? You see, those kind of things. These are the things that they need to be able to do. You see, if we bring it to our place, things like writing and presenting clinical history, we teach on that. Writing and presenting a treatment or management plan. Logically making a diagnosis from client data. It cuts across the health sciences. And it's actually linked to those things up there. But we need to get them to be able to do those things. A doctor graduates. He or she should know how to take minutes. You understand? You say that, but taking minutes, well, that might determine whether the person gets that job or not. Because when you are the most junior person you get there, the meeting is going to say, take notes. Then bring minutes. And it's like, what is minutes? Where's the secretary? No. You take notes. This confidential meeting, you're not bringing the secretary in. So these are some important industrial skills that we need to work into our curriculum and our teaching. A very crucial skill. Ability to conduct research. These are things that at every level, undergrad, whatever, we should make sure that we work into that. So, partnerships with industry. The school can lead. The lecturer should also lead. If your school is not doing it, and if you say that because the school is not doing it, I won't do it. No, it won't help you. Get there. You have friends who are out there. Getting those partners. And the students also can suggest. Some of those people we teach, they are very highly connected. Understand? These days that people are doing what their parents are doing. And then you find out from them, and somebody's dad is the head of that, of GSK or AstraZeneca, and you are sitting down there wondering how to get that connection. So because that child is going to get that AstraZeneca exposure because of the father anyway. So what you're going to do is that if your father is AstraZeneca, all of us will go, your colleagues will go with you. You are not the only one who benefit from it. You know, and then industry-led. We like, when industry approaches us, let's let industry know that we want to be approached. And when they approach us, let's develop some of those partnerships also. And if you have a partnership, use it. You've developed a partnership, make sure that students always go there, or very soon they forget about you. I mean, and then interact with the people, talk with them, and let industry be involved in the student assessment. You see, you don't realize it. I mean, we have industry people here, but they actually look up to us academics. So when they see us working, they are like, Charlie, the people have knowledge in their head. You understand? What they are doing is big. And when you bring them into your class and say they should help, they should assess the students, they haven't even finished that class, so it's on their CV. You understand? I mean, co-teaching of this course with Professor this. It's a big thing. You know, so industry value us. Let's put ourselves out there. Get them involved in student assessment. You'll be surprised at the questions they'll be asking. Then you also learn, and then next time you note it and you ask those questions. And then when the students are graduating or doing things, invite your partners so that they know that they are a part of what you are doing, and they don't only see you when students go out there. So I've said this already about the curriculum process. Let the school set standards for all departments. Head of department set standards for courses taught in the department. And then we must review the curriculum as time goes on. Then I think, yeah, I'll end with this one. Our teaching. This is the last one. This is my pet fight with university, and I'm university product too. Don't think I'm not. You see, the nice thing at university is that you go out, you go and do a PhD, you come out with flying colors, then you are admitted, and you are told, go and teach. And we tell ourselves that we are the teachers. But see, I'm declaring to all of you that we university lecturers, we are not trained teachers. Do you realize that? We are not trained teachers. Some of us are very, very bad teachers. You understand? I mean, we stand there and we talk to ourselves and we think we are talking, we don't engage with the people. So we need to have some mechanism by which we are helped to teach, and where our teaching is also assessed, not the punitive one. There was an interesting, you can tell them I said this. I mean, at the time, Legon was doing, maybe I'm still doing it. It was like teaching assessment as part of your promotion. I was dean then. I saw the first two, and I was like, this is a waste of time. Because it's tied to your promotion. Everybody's getting 90%, 85, 98. I was like, this is a waste of my time. So anytime it came, I didn't even look at it. I just signed it and then added it to the dossier, let it go. Because that was not a thing that developed anybody. So let's take a non-punitive one where your peers would come in and then look at that and give you feedback on how you teach and help you to improve. And then let's have a system whereby some universities have it. They are certified teaching courses that we all have to take, kind of like to keep on teaching. As we do those things, they might help us achieve something good. So, thank you.
I think we can clap again for all our three speakers. They've done very well. Yes, we knew this morning's session, and we can imagine what is also to come. We want to quickly go into a question and answer session, and then after we'll take a break, we'll go into a snack break. But when we are going for the snack break, we want to plead with you. We want to take a group photo. You want to remember that you met Dr. Nanteti. So we'll take a group photo outside. So we'll quickly do a question and answer session. Please help me put the chairs. Yeah, there. So I want to invite our first three speakers to please come up stage, and then it won't be long. I know you are very tired. Just briefly engage us in a question and answer session. kindly give us the lights. Please put the lights on for us. And then, as promised, you take it. Okay. So, the microphone will come around. So those who have questions, to kindly. He was going to take it around for us. So I hear the ushers have the microphones. So if you kindly raise your hand to indicate you have a question, I would hand this over to our speakers in no particular order, because you are first. But the question may go to
you hold it.
Okay, so Dr. Mayao.
Thank you. My question goes to Dr. Nyantechi. I saw on your slide that about 70% of laboratory investigation could be wrong. I want to be corrected. I saw something like that. The slide went fast. See, so if I'm wrong, because I am saying this because as people have been saying, or the lab scientists have been saying, without us, doctors can't make diagnosis, because we depend, or doctors depend very much on diagnosis. I'm saying this because a cousin of mine called me somewhere August 28 that he was urinating and getting tired. So I asked him if he had done some tests, he had gone to hospital. Then he forwarded some laboratory investigations to me, because he is 63. And at this age, I was thinking of two things: either diabetes mellitus or prostate enlargement. So he said to me, the fasting blood glucose was 5.4, which was normal. And then the prostate PSA was 5.02 nanogram per nanoliters. And that put it at a higher range, having big range. So I rather referred to a urologist that I called one of the urologists and said, well, this is what my cousin is having, and these are the laboratory investigations. So I went, and probably he also started on some investigation. He started on some treatment and said he should go and do some investigation. And when he went and did the investigation,
Sandra, if you cut it.
And so, with this, I really, it was, the problem was diabetes and not age, as the guy had. So my problem is, at times, I have the laboratory investigation, I come out of the lab.
Thank you, Dr. Mayer. So,
but the problem is, at times, some of these things, you get the investigation from the lab, and you are wrong because the laboratory is wrong. So, in some of these conditions, not treating the patient, not treating laboratory investigation, but treating the patient, what do you do? And some of them may be deadly. I am saying this because we get ill when we are well. So it is the laboratory that tells us that, oh, at this stage, you need to take some steps so that you can reverse or stop or prevent or treat some diseases.
Thank you very much, Dr. Mayer. So we'll take two more questions. I want to plead with the House if we can make it a bit brief so they have a chance to respond to us. Two hands up. Okay, so after Prof's question.
I'm going to say something. I think my first question goes to Dr. Nyantechi Sechere. And then the next one will be for Prof. Adanu. As part of your presentation, I'm also with the diagnostics. I'm a pathologist. As part of you made mention of the fact that about 70% of misdiagnoses come from what? The laboratory. Or wrong diagnosis.
So he will clarify that. He will clarify that for us.
Come again. What did he say?
Prof, I'm told he didn't say that, but he will have the chance.
Okay, that's fine. If he didn't say that, that's okay. But then there's an observation here. As a pathologist, one observation I've made is that, especially most of us surgeons here sitting with us, they will do appendicectomy, divide the specimen into two. One goes to another lab, another part of the specimen goes to another lab, with the hope that whether to try to see whether the two diagnoses will be the same. In the sense that one of the, probably if you have, let's say, maybe acute appendicitis from anything, maybe fecalis and all those things, and then you probably diagnose that. And he has sent another one. That site tells you that it's a normal appendix. And so automatically, which of them is he going to take? So what we try to do is that, in fact, some of the doctors even don't write their telephone numbers. They don't give any indication. So when you are at your weight end, you want to even call the doctor that, look, this is the situation. You won't get. I don't know whether it's by design or accident or intentional. So they are all here. They know what I'm talking about. And then aside that, the other one also goes to, in fact, anytime we, the academia, we think of something like industry, we feel, industry is those of us, probably if you're a doctor, you expect a doctor to come to your clinic and all those things, especially if you're a private practitioner. But have you thought of people like Despite Osei Kwame? Have you thought of people like Ofori Sapong? Have you thought of people like Magazine, those people at Magazine, engineering students? Can't you also have some collaboration? Elsewhere in the world, they do that. In collaborations with those people who would feel that they are not academic inclined, so that we send our students there so that they go and learn something about what they are doing in the classrooms. For instance, the engineering student, I don't know whether engineering students, some people bring their cars here for them to repair. I'm not too sure. But if they don't do that, why can't we send some of our students there to go and learn those things that hitherto were being crude in terms of the way they handle it? So that we think of industry, not only academic industry, but then people who are also outside somewhere, who are entrepreneurs and who are also some as it were, doing some form of engineering, maybe in the crude manner. Thank you.
Thank you, Prof. Is it okay to take one more question, or do you want to answer now? Okay. Please go ahead.
Okay. I know media is here, so let me clear myself very well. I have never said that. I think this is a literature. That is why we are in academia. It's not my work. It's a literature research that have shown that 70 at least, or something like that, most people know this, decisions that clinicians make are based on medical diagnostics. So the point I was making is that, just like our teachers, if we are going to rely 70% of our decisions to manage patients on laboratory, then it is important we make sure there's people we put in these positions are trained very well. Am I clear? Good. Then the first one, again, this is where the problem comes. Let us go to the first principles of how we manage patients. If we have sufficient doctors, nobody should walk into a lab and do tests. Okay? At least I remember this. This is how I was taught in medical school. So if I'm wrong, then the entire faculty of medicine at Hopkins, they are wrong. They made sure we know how to take good history. So there's a course on doctor-patient communication. Because if the patient is not giving you the right information, there's no way you're going to make the right diagnosis for them. So emphasis was made during medical training for me to learn how to take good history. And you used to say at Hopkins that 90% of the time, by good history, you already know what is going on. The rest that is coming is physical examination. So you're going to have to do a targeted physical examination to help you. And then the 5% is just going to be, now I have a differential diagnosis. Let me now request the test. And if we can understand, so it does not necessarily mean that 5% raw diagnosis is going to play. It is not making it unimportant, because it is important that I really confirm the diagnosis. So this is the role. So this idea that whether lack of resources, people just walk in and do medical tests. Again, the profession of medical tests will tell you what happens to random error. What happens to that? That is what we can do tomorrow to let people, because most of the students coming out have no idea that there is a random error. And that random error means you've taken care of everything, your quality control, quality assurance, calibrations, everything is well. Yet, there's 1 in 20 chance that you get a random error. And it's a very simple thing. It's a normal distribution curve. You take a normal, everybody can take full blood count sample. Run it 20 times. One of the results is going to be wrong. So this is not, the reason I came here is to try to share the seriousness of healthcare, that we have just made it like, oh, anybody can just walk in and set up a lab and just run it. It's not like that. Thank you.
Thank you very much.
Okay.
Yes. Yeah. There was part of the question that was...
Okay, I guess the part of the question that was probably directed at me is the one about where is industry? And there were 2 questions I put up there. Who's the largest employer of our graduates? And then who has the highest standards? I think if we apply those things, we'll identify who industry is. Now, you made examples that are relating to engineering, but engineering is not here. But let me pick that. If none of the graduates from engineering go to Israel magazine, you said, if none of them go there, really, you are not training your people for them to fit into that place. So you can't send your students there thinking that it's an experience that will help them when they graduate. Now, if, however, you have discovered that there is some practice going on in that place, although your students are not employed there, which your students can benefit from, then your students can do an attachment there. That comes out in the familiarization thing. As you are teaching, you're asking yourself, where is it that my students can learn these objectives that I've set out? And then you get them there. So nobody is saying that the only industry is the formal one. And some of the informal ones actually employ our students and have very high standards. So there's no limit to say that it must be a place with an organogram, whatever. No, you just ask yourself, who's the largest employer, who has the highest standards, where can my students learn something? And you adjust things appropriately. And if, for instance, if your students are not employed by a particular place, what you take your students to learn from there is different from where you take them to an industry where they are employed in. The targets are totally different. So in all this, we must know what we are seeking to achieve as we send the students out.
Thank you very much. So last question for this session.
Okay, thank you very much. I'm Timothy from the nursing department. When Dr. Yantechi was making his submissions, he mentioned fractured communication. And he made reference to the fact that there is a lack of team working at the hospital setting. For instance, where we should have multidisciplinary team consisting of the doctor, the nurse, occupational therapist, physiotherapist. In the hospitals, you go there, these things are not there. does it mean that maybe the universities are not doing needs assessment to know that the ratio of doctors being trained is not proportional with, let's say, physiotherapists or, let's say, the psychiatrist, so that out of that needs assessment, they can come up with curriculum that will ensure that all level players, I mean, like those that must function a multidisciplinary team, are there to ensure that teamwork goes on in the hospital so that the patient will benefit. So that's my submission. Thank you.
That's more about universities, isn't it?
Would you like to respond?
Yes, just are we
All right.
doing our needs assessment well to know that these kinds of, let's say, this group of practitioners are needed? So can we come up with a curriculum to...
Your question is understood. We're just debating ourselves that what you are asking is a question you're asking the university and not Dr. Nyantechi. So at this point, I am the university. So let me just try and address that. You see, promoting teamwork is different from talking about the ratios of people being turned out. Because as we sit here, when you take doctor-patient ratio and you go beyond to like even specialist-patient ratio, Ghana hasn't achieved what is expected. You understand? Despite the growing numbers of people coming to medical school, we've still not met the doctor-patient ratio. The load per doctor is too big. And I think for nurse-patient ratio, I mean, if I'm right, I think we've kind of like met that by the WHO standards. But then when it comes to pharmacists, we haven't met it. I mean, I was at the graduation of the College of Pharmacy, and when they gave the ratios out there, we haven't met it. You understand? I don't know about the physiotherapists and the others. So teaching teamwork doesn't depend on the ratios. Teaching teamwork, like Dr. Nyantechi said, is dependent on our curriculum and getting these people from the level of being students, knowing that they need to work together. We're a College of Health Sciences. Why we talk about things like problem-based learning? Why can't we have a problem that is being shared between the medical school class, the nursing class, the pharmacy class, and they work together on that project and come out with a solution that recognizes the contribution of everybody? Rather than taking that problem, you give it to nurses, they come out with a nursing solution, pharmacists come out with a pharmacist solution, the doctors come out with a medical solution, and when the three of them meet on the ward, each one feels that I've done this before and I know how to handle it. And they don't know how to work with each other. So those are things that, we didn't go into that in the curriculum development, but then the whole cross, and this is usually done best in projects. Yeah.
Thank you very much. So I wrote a question down. I know you mentioned that Abuja Declaration, and then how academia can support industry and vice versa. Dr. Morrison and Dr. Nentiti. But in academia, research is driven by funds. So are you able to give us some practical steps? For instance, would MDS, would NHIA be willing to support academia in terms of supporting research funding? What would be a practical step? Maybe we can compete for it by putting our proposals together, but any ideas?
Okay. Yes, academia needs, like I said, industry needs academia, definitely. Without that, there can't be any forward move. But the point is that we in academia, in industry, have specific issues and problems. And that is what we want analyzed and, for that matter, researched into. I gave the example of Tamaoye Refinery. They had a peculiar problem. The approach is the same KNUST they approached. The problem was solved. They went back. They sponsored, they partnered.
Nautical College had a problem. They approached us. Together, we were able to solve the problem. NHI, yes, we realized the problems that out there, facilities were, as it were, shelving or, a folder or a patient folder with you has a lifespan that it goes through. So the folder must be active for 5 years. So if the patient comes this year and you don't see the patient next year, it doesn't mean that that folder should be declared inactive. No, there are guidelines. But unfortunately, it looks like those in the field probably were unaware of this. So they will just take it somewhere, pack them, typex the names, and recycle them. That is wrong. So that teaching, we went from region to region, collecting those who engage in NHI, that is health insurance, and bringing this forward. These were in the early years of 2005, 2008. Today we don't have, but at least we all learned something. So there is that kind of collaboration to solve a problem. So we identify a problem, and then we tell academia, this is the problem. How do we together solve that problem? And we are definitely prepared to fund. But not when you come with a gargantuan PhD problem, which does not sit well with industry. Certainly we won't have the money for it.
Yeah. MDS Lancet has been supporting our academia research. I'm not sure, but we've been, especially postgrads, we have offered 20 to 30% discount, meaning we do the test for them at cost, especially when they need an accreditation to support their research. So it's something that we do. And currently we have about 5 doctors that we are supporting. And not only doctors, we've done for pharmacists at the PhD level. Yeah.
Thank you very much.
And Dr. Ntiji said he's shy. He's a shy person, so he doesn't like to talk about other things that he does. And MDS Lancet is also involved in the training of laboratory physicians for the Ghana College of Physicians and Surgeons. So our trainees go to MDS Lancet. They rotate through there. They are taught on these current machines that exist. So these are doctors going there, working with laboratory scientists, and they get their training and come out and are very well rounded. And that also is money that they are putting into training, because they don't charge us for these people coming out there. Am I making it up?
Thank you very much. So I'd like to call on Professor Cynthia Meni to help give a token, just to say thank you to our facilitators for the first session. Okay. Provost, we want you to please help us present the items to our facilitators. Thank you very much. So we will now draw the curtain for the first session. We'll take the photograph, the group photograph outside. Then we'll have a snack break. But we want to plead with you. We know the second session will be extremely exciting. So please don't stay out for too long. Because you are senior members, we want to tell you now, because it will be difficult to bring you back in. So please, yes. Not more than 20 minutes. So please take your snack. Take your snack and then kindly come back. 12 o'clock. By 12 o'clock, we want to be in our seats. Yes, but the group picture is first. So group picture now, and then group picture now. Thank you. Snack is served on the first floor. Snack is served on the first floor. Snack is served on the first floor. Thank you. Thank you so much. Then your slides. And do we have permission to share? Thank you so much. Thank you very much.
The Department of Global Health was set up because there was a realization of a need for training in public health that went beyond local situations. As you know, there has been talk about community health, public health, international health, and now really global health is at the forefront of regarding health in general. The recognition that the world is highly interconnected, and that when there is a sneeze in one part of the world, somebody else will be catching a cold on the other side of the world. That means that understanding these interrelationships and how they work is critical. Also understanding how same problems may pan out differently or may involve different factors in different parts of the world is so critical. And this is why we realized as a School of Public Health that there's a need for training of students in this way of thinking and understanding the way the world works and the way health across the world works, and hence the need for global health. If for anything at all, the COVID-19 pandemic has taught us that everybody is interconnected and understanding health globally is so critical. We work in tandem with the Ministry of Health, with the Ghana Health Service, and then with the health partners in the country, the WHO, the UNICEF, the World Visions, and the many others that operate in health in Ghana, USAID, the FCDO, and several others. My expectation and hope is that we will be able to get our students to understand the way our Ministry of Health and especially our Ghana Health Service interface with some of these bodies, both locally and internationally. We, for example, have something known as international health regulations. What does it mean if there's an outbreak in a country to report, and how timely should you report? How should you go about the reporting? What does it imply beyond just health for the country and for the continent of Africa and globally? So really looking to interface with the Ministry of Health, the Ghana Health Service, and the health partners to make sure that students have that well-rounded training that they need to be able to operate optimally. Yeah, my expectation is that with the training of more global health professionals and students, we'll be able to have people trained right here in Ghana who have an outlook that goes beyond the country into the entire African continent, and not only the African continent but across the whole world. It's about time that in Africa and in Ghana also, we tell our own story, we describe our own problems, and we...
Be a part of the KNUST Day of Giving, 3rd October 2023.
Hello, my name is Professor Mrs. Rita Akusia Dixon, Vice Chancellor and proud alumna of the Kwame Nkrumah University of Science and Technology, Kumasi. I am definitely donating to express my appreciation and support to this wonderful university that has contributed so much in making me who I am today on the 6th of October 2023. Hashtag KNUST Day of Giving.
To donate, dial *887*1350# or log on to knustdayofgiving.knust.edu.gh. Donate in any major currency. Be an early donor and donate now. For more information, please call 020-110-5000. Hashtag KNUST Day of Giving.
Be a part of the KNUST Day of Giving, 3rd October 2023.
Hello, my name is Professor Mrs. Rita Akusia Dixon, Vice Chancellor and proud alumna of the Kwame Nkrumah University of Science and Technology, Kumasi. I am definitely donating to express my appreciation and support to this wonderful university that has contributed so much in making me who I am today on the 6th of October 2023. Hashtag KNUST Day of Giving.
To donate, dial *887*1350# or log on to knustdayofgiving.knust.edu.gh. Donate in any major currency. Be an early donor and donate now. For more information, please call 020-110-5000. Hashtag KNUST Day of Giving.
Be a part of the KNUST Day of Giving, 3rd October 2023.
Hello, my name is Professor Mrs. Rita Akusia Dixon, Vice Chancellor and proud alumna of the Kwame Nkrumah University of Science and Technology, Kumasi. I am definitely donating to express my appreciation and support to this wonderful university that has contributed so much in making me who I am.
Be a part of the KNUST Day of Giving, 3rd October 2023.
October 6th every year has been declared as a KNUST Day of Giving. It's a day set aside for students, staff, alumni, and other stakeholders to give back to the university. This year's event has been scheduled for 6th of October 2023 and is aimed at raising 200 million Ghana cedis to construct another hall of residence. My name is Andrew Kwesi, the Registrar of KNUST, and I'm proud to be associated with this noble cause. And I urge all our stakeholders to contribute to this worthy cause. Hashtag KNUST Day of Giving.
To donate, dial *887*13.
Be a part of the KNUST Day of Giving, 3rd October 2023.
October 6th every year has been declared as a KNUST Day of Giving. It's a day set aside for students, staff, alumni, and other stakeholders to give back to the university. This year's event has been scheduled for 6th of October 2023 and is aimed at raising 200 million Ghana cedis to construct another hall of residence. My name is Andrew Kwesi, the Registrar of KNUST, and I'm proud to be associated with this noble cause. And I urge all our stakeholders to contribute to this worthy cause. Hashtag KNUST Day of Giving.
To donate, dial *887*1350# or log on to knustdayofgiving.knust.edu.gh. Donate in any major currency. Be an early donor and donate now. For more information, please call 020-110-5000. Hashtag KNUST Day of Giving.
Be a part of the KNUST Day of Giving, 3rd October 2023.
October 6th every year has been declared as a KNUST Day of Giving. It's a day set aside for students, staff, alumni, and other stakeholders to give back to the university. This year's event has been scheduled for 6th of October 2023 and is aimed at raising 200 million Ghana cedis to construct another hall of residence. My name is Andrew Kwesi, the Registrar of KNUST, and I'm proud to be associated with this noble cause. and I urge all our stakeholders to contribute to this worthy cause. Hashtag KNUST Day of Giving.
To donate, dial *887*1350# or log on to knustdayofgiving.knust.edu.gh. Donate in any major currency. Be an early donor and donate now. For more information, please call 020-110-5000. Hashtag KNUST Day of Giving.
Be a part of the KNUST Day of Giving. Said October 2023.
October 6th every year has been declared as a KNUST Day of Giving. It's a day set aside for students, staff, alumni, and other stakeholders to give back to the university. This year's event has been scheduled for 6th of October 2023 and is aimed at raising 200 million Ghana cedis to construct another hall of residence. My name is Andrew Kwesi, the Registrar of KNUST, and I'm proud to be associated with this noble cause. And I urge all our stakeholders to contribute to this worthy cause. Hashtag KNUST Day of Giving.
To donate, dial *887*1350# or log on to knustdayofgiving.knust.edu.gh. Donate in any major currency. Be an early donor and donate now. For more information, please call 020-110-5000. Hashtag KNUST Day of Giving.
Be a part of the KNUST Day of Giving. Said October 2023.
October 6th every year has been declared as a KNUST Day of Giving. It's a day set aside for students, staff, alumni, and other stakeholders to give back to the university. This year's event has been scheduled for 6th of October 2023 and is aimed at raising 200 million Ghana cedis to construct another hall of residence. My name is Andrew Kwesi, the Registrar of KNUST, and I'm proud to be associated with this noble cause. And I urge all our stakeholders to contribute to this worthy cause. Hashtag KNUST Day of Giving.
To donate, dial *887*1350# or log on to knustdayofgiving.knust.edu.gh. Donate in any major currency. Be an early donor and donate now. For more information, please call 020-110-5000. Hashtag KNUST Day of Giving.
Be a part of the KNUST Day of Giving. Said October 2023.
October 6th every year has been declared the KNUST Day of Giving. It's a day set aside for students, staff, alumni, and other stakeholders to give back to the university. This year's event has been scheduled for 6th of October 2023 and is aimed at raising 200 million Ghana cedis to construct another hall of residence. My name is Andrew Kwesi, the Registrar of KNUST, and I'm proud to be associated with this noble cause. And I urge all our stakeholders to contribute to this worthy cause. Hashtag KNUST Day of Giving.
To donate, dial *887*1350# or log on to knustdayofgiving.knust.edu.gh. Donate in any major currency. Be an early donor and donate now. For more information, please call 020-110-5000. Hashtag KNUST Day of Giving.
Be a part of the KNUST Day of Giving. said October 2023.
October 6th every year has been declared as the KNUST Day of Giving. It's a day set aside for students, staff, alumni, and other stakeholders to give back to the university. This year's event has been scheduled for 6th of October 2023 and is aimed at raising 200 million Ghana cedis to construct another hall of residence. My name is Andrew Kwesi-Boateng, the Registrar of KNUST, and I'm proud to be associated with this noble cause. And I urge all our stakeholders to contribute to this worthy cause. Hashtag KNUST Day of Giving.
To donate, dial *887*1350# or log on to knustdayofgiving.knust.edu.gh. Donate in any major currency. Be an early donor and donate now. For more information, please call 020-110-5000. Hashtag KNUST Day of Giving.
Be a part of the KNUST Day of Giving, said October 2023.
October 6th every year has been declared as the KNUST Day of Giving. It's a day set aside for students, staff, alumni, and other stakeholders to give back to the university. This year's event has been scheduled for 6th of October 2023 and is aimed at raising 200 million Ghana cedis to construct another hall of residence. My name is Andrew Kwesi-Boateng, the Registrar of KNUST, and I'm proud to be associated with this noble cause. And I urge all our stakeholders to contribute to this worthy cause. Hashtag KNUST Day of Giving.
To donate, dial *887*1350# or log on to knustdayofgiving.knust.edu.gh. Donate in any major currency. Be an early donor and donate now. For more information, please call 020-110-5000. Hashtag KNUST Day of Giving.
Be a part of the KNUST Day of Giving, said October 2023.
October 6th every year has been declared as the KNUST Day of Giving. It's a day set aside for students, staff, alumni, and other stakeholders to give back to the university. This year's event has been scheduled for 6th of October 2023 and is aimed at raising 200 million Ghana cedis to construct another hall of residence. My name is Andrew Kwesi-Boateng, the Registrar of KNUST, and I'm proud to be associated with this noble cause. And I urge all our stakeholders to contribute to this worthy cause. Hashtag KNUST Day of Giving.
To donate, dial *887*1350# or log on to knustdayofgiving.knust.edu.gh. Donate in any major currency. Be an early donor and donate now. For more information, please call 020-110-5000. Hashtag KNUST Day of Giving.
Be a part of the KNUST Day of Giving, said October 2023.
October 6th every year has been declared as the KNUST Day of Giving. It's a day set aside for students, staff, alumni, and other stakeholders to give back to the university. This year's event has been scheduled for 6th of October 2023 and is aimed at raising 200 million Ghana cedis to construct another hall of residence. My name is Andrew Kwesi-Boateng, the Registrar of KNUST, and I'm proud to be associated with this noble cause. And I urge all our stakeholders to contribute to this worthy cause. Hashtag KNUST Day of Giving.
To donate, dial *887*1350# or log on to knustdayofgiving.knust.edu.gh. Donate in any major currency. Be an early donor and donate now. For more information, please call 020-110-5000. Hashtag KNUST Day of Giving.
Be a part of the KNUST Day of Giving, said October 2023.
October 6th every year has been declared as a KNUST Day of Giving. It's a day set aside for students.
I'm fabricating for a patient. The patient has a labialized upper anterior tooth. It's out of the arch or the occlusal plane. So the purpose of this appliance is to fabricate a modified labial bow. I'm Dr. Henry Emmanuel Nyanko, and I'm alumni of KNUST Dental School, pioneer as such. I completed in 2012. You were 18 number who came out, and I did my house job at Konfanochi Teaching Hospital 2012-2013. Then in the year 2014-2015, I did my second year house job at Kintampo Oral Health, where I worked and I also teach as part of the requirement. Then later in 2015, I came back to Kumasi, where I was posted to Menchia District Hospital. I served for about 5 years. That's from 2015 to 2020. Then I came back to do my membership program, where I'm in my second year. I'll be going to my third year come September. So the journey has been good, except being the pioneer. We didn't have any seniors to look up to. Sometimes there were doubts, there were struggles, but it all came out good. I'm fabricating for a patient. The patient has a labialized upper anterior tooth. Is out of the arch or the occlusal plane. So the purpose of this appliance is to fabricate a modified labial bow. Dr. Henry Emmanuel, and I'm alumni of KNUST Dental School, pioneer as such. I completed in 2012. You were 18 number who came out, and I did my house job at Konfanochi Teaching Hospital 2012-2013. Then in the year 2014-2015, I did my second year house job at Kintampo Oral Health, where I worked and I also teach as part of the requirement. Then later in 2015, I came back to Kumasi, where I was posted to Menchia District Hospital. I served for about 5 years. That's from 2015 to 2020. Then I came back to do my membership program, where I'm in my second year. I'll be going to my third year come September. So the journey has been good, except being the pioneer. We didn't have any seniors to look up to. Sometimes there were doubts, there were struggles, but it all came out good. I'm fabricating for a patient. The patient has a labialized upper anterior tooth. Is out of the arch or the occlusal plane. So the purpose of this appliance is to fabricate a modified labial bow. Dr. Henry Emmanuel, and I'm alumni of KNUST Dental School, pioneer as such. I completed in 2012. You were 18 number who came out, and I did my house job at Konfanochi Teaching Hospital 2012-2013. Then in the year 2014-2015, I did my second year house job at Kintampo Oral Health, where I worked and I also teach as part of the requirement. Then later in 2015, I came back to Kumasi, where I was posted to Menchia District Hospital. I served for about 5 years. That's from 2015 to 2020. Then I came back to do my membership program, where I'm in my second year. I'll be going to my third year come September. So the journey has been good, except being the pioneer. We didn't have any seniors to look up to. Sometimes there were doubts, there were struggles, but it all came out good. I'm fabricating for a patient. The patient has a labialized upper anterior. Is out of the arch or the occlusal plane. So the purpose of this appliance is to fabricate a modified labial bow. Dr. Henry Emmanuel, and I'm alumni of KNUST Dental School, pioneer as such. I completed in 2012. you were 18 Nama who came out, and I did my house job at Konfanochi Teaching Hospital 2012-2013. Then in the year 2014-2015, I did my second year house job at Kintampo Oral Health, where I worked and I also teach as part of the requirement. Then later in 2015, I came back to Kumasi, where I was posted to Menchia District Hospital. I served for about 5 years. That's from 2015 to 2020. Then I came back to do my membership program, where I'm in my second year. I'll be going to my third year come September. So the journey has been good, except being the pioneer. We didn't have any seniors to look up to. Sometimes there were doubts, there were struggles, but it all came out good. I'm fabricating for a patient. The patient has a labialized upper anterior tooth. It's out of the arch or the occlusal plane. So the purpose of this appliance is to fabricate a modified labial bow. I'm Dr. Henry Emmanuel, and I'm alumni of KNUST Dental School, pioneer as such. I completed in 2012. You were 18 Nama who came out, and I did my house job at Konfanochi Teaching Hospital 2012-2013. Then in the year 2014-2015, I did my second year house job at Kintampo Oral Health, where I worked and I also teach as part of the requirement. Then later in 2015, I came back to Kumasi, where I was posted to Menchia District Hospital. I served for about 5 years. That's from 2015 to 2020. Then I came back to do my membership program, where I'm in my second year. I'll be going to my third year come September. So the journey has been good, except being the pioneer. We didn't have any seniors to look up to. Sometimes there were doubts, there were struggles, but it all came out good. I'm fabricating for a patient. The patient has a labialized upper anterior tooth. It's out of the arch or the occlusal plane. So the purpose of this appliance is to fabricate a modified labial bow. I'm Dr. Henry Emmanuel, and I'm alumni of KNUST Dental School, pioneer as such. I completed in 2012. You were 18 Nama who came out, and I did my house job at Konfanochi Teaching Hospital 2012-2013. Then in the year 2014-2015, I did my second year house job at Kintampo Oral Health, where I worked and I also teach as part of the requirement. Then later in 2015, I came back to Kumasi, where I was posted to Menchia District Hospital. I served for about 5 years. That's from 2015 to 2020. Then I came back to do my membership program, where I'm in my second year. I'll be going to my third year come September. So the journey has been good, except being the pioneer.
Graduates. So for this second session, our first speaker is Professor Mahama Duwejua. Prof. Mahama, I can do the first line introduction and say that he taught me in school. So that one I can say without having to read. But ladies and gentlemen, I have the pleasure to introduce to you our next presenter in the person of Professor Mahama Duwejua, a fellow of the Ghana Pharmaceutical Society, fellow of the West African Postgraduate College of Pharmacists, and fellow of the International Pharmaceutical Federation. Prof. Duwejua is a well-known past senior member of the Faculty of Pharmacy. He served in the university for about 30 years and occupied various positions in the faculty, like head of Department of Pharmacology, head of Department of Clinical and Social Pharmacy, now known as Pharmacy Practice, Vice Dean, and finally Dean of the faculty. Prof. Duwejua left the faculty in October 2010 to take up a position as Executive Secretary of the National Council for Tertiary Education, now GTEC, till September 2016, where he retired. He returned to the faculty and served for 2 years before taking up a post-retirement contract appointment as Professor of Pharmacology at the School of Pharmacy, University of Ghana. He's well known in pharmacy within Africa and globally, and has served as examiner to the West African Postgraduate College of Pharmacists, and now second vice chairman of the college. He's an examiner in pharmacology to the medical school in the University of Gambia, and also examined in clinical pharmacy at the University of Nairobi, Kenya. As I said this morning, we have highly qualified health professionals. So if I want to take every detail on the introduction, we won't finish. So please permit me to just read another important part, then I'll round up. Prof. Duwejua is also a founding member of the FIP UNESCO's Africa Center of Excellence in Pharmacy. So ladies and gentlemen, I want to present to you Professor Duwejua, the second vice president of the West African College of Pharmacists and vice chairman of the Professional Qualifying Examinations of the Pharmacy Council of Ghana, chief examiner of the Ghana College of Pharmacists, and professor of pharmacology, as well as lecturer in pharmacy practice, School of Pharmacy, University of Ghana. Please, let's welcome him.
Thank you very much. You will realize I'm the only one who has a slide like this. Professor Adenu didn't use it. Professor Aite didn't. And it's intentional because what I got from Cynthia listed me as former executive secretary of the National Council for Tertiary Education. University of Ghana pays me now, and if they see that I have listed myself, you don't want me to have a job. That was the reason why I changed my slides to let University of Ghana know that whatever is here is not my doing. I am not. Okay? And I see there's no Nigerian here. But there's an interesting incident. Well, let me see you by hand. Very good. I had an invitation from a colleague in Jos. He said, we're organizing this and I want you as keynote speaker. I said, okay, let me think about it. He said, all right, I'm putting you on it. You be thinking. You know. So, and that is Nigeria. Very nice sense of humor there. So when I got this invitation, I didn't want that. I said, okay, I accept. Yes. So there we are. Here, I want to put my presentation in context by going back to this portion, part of the theme, developing industry graduates through effective partnership. And that is extremely important, effective partnership. I will give you two stories that will illustrate this. This one is the launching of the CSR Training Institute, Corporate Social Responsibility. It was on the 23rd of August and had quite some powerful people there. This gentleman is the presidential advisor on SDGs. This Mawina Trevor is Komla Dumo's sister, and you have somebody there who is from AGI, and then Bensu Oil, and then Anglo Gold. They were all speakers, and I was supposed to give some remarks after this. Whilst we waited, they were playing something on corporate social responsibility, and they said, this is about maximizing social returns. It is devoid of the high academic rhetoric. I was sitting there. I'm there, you say that high academic rhetoric. And rhetoric means high-sounding language meant to persuade or convince. But when you look into it, you really don't find any substance in the talk. And I said, is this what you people are thinking of us? And you invite me to come. Professor Wayne Dunn, he is the owner of that thing. But I had a similar experience years back. Many of you know this gentleman, Leo Kran. Yeah. I went to, when I was with the NCT, I went to the minister and I said to him that, Honorable, the universities want to go on strike. You have to do something. He said, about what? I said, about market premium. And he said, you know me sitting here, as a minister, you know my market premium. I don't get anything. And you say professors want to go on strike. What do they do? 60 years after independence, we are still carrying things on our head. And you tell me they want to go on strike. I said, Honorable, I'm here. He said, I know, you are one of them. You know, if you know Leo Kran, that's the way he talks. But these stories tell you what people outside think of us. They don't think we are doing anything, much as we think that we are doing a lot. So yesterday when the Vice Chancellor in her welcome address said that we are reputed to be the best university globally as far as quality education is concerned, I said, You know, Professor Andam used to say we're number 4 in the world. Today we are number 1. Something is happening. But the point is this. Who says that? Are we just tickling ourselves and laughing? Because it looks like our stakeholders don't see it that way. But they are very important. The stakeholders are the reason why we exist. And if they don't value us, something is missing. We need to be careful. I want to show you a statement from the International Pharmaceutical Federation and what they think of the role of stakeholders, extremely important. This is from their Centennial Declaration. It says that pharmacists and pharmaceutical scientists accept responsibility and accountability for improving global health and patient health outcomes by closing gaps in the development, distribution, and responsible use of medicines. They didn't end there. Society can contribute to these objectives by supporting the advancement of pharmacy practice and the pharmaceutical sciences. That is a powerful statement, recognition of society. These are the stakeholders. We can't do anything without them. They hold the money and we work for them. That is the reason why we exist as professionals in every field. So when you talk about partnership, effective partnership, it's in recognition of that. We say we really mean well in what we are doing, but then we need to think again. The people who invest in education think otherwise. And society has got expectations of our profession we may not be meeting. You have come across all of us, whether you're a doctor or pharmacist or a lab man, you hear people say, oh, in fact, there was if, say, you are in the pharmacy in the community, somebody comes to you and then you tell him that, look, listen, go to the hospital. And he refuses. What a funny excuse. You see? What is happening? If I'm using my judgment to say go and you said I won't go, there's something. Then it's the same thing with many of us and society's expectations. So, again, but we must recognize that the current problems, and this is what the lab man was saying, we need to work as a team. The current problems, health problems, are so complex that they are beyond the professional competence of any one person. And we have to work as a group so that society will derive the best, maximum benefit from the investment in us. And this one we talk about partnerships. It's part of it. Our students' expectations are also changing. They are very smart. Professor Adenu said it. You were talking, and the students are sitting there. And in fact, those of us who are used to going to, say, YouTube or some other place to download things, they have already seen them. They've seen it. So you could put the same thing, but make sure that you deliver it in a way to show that you are senior to him. He may just read through. Okay? And I don't hide it, actually, when I've done that. I'll do my own modifications, and I tell them the source. You can go, I'm not afraid to say it, but you have to present yourself competently. Okay? So the other thing about the students, we must take advantage of technology. If you don't, these days, ChatGPT and all these AI things, the students are so smart. They can use these things to cheat you. Actually, we are seeing it with the top-up students, those pharmacists who are outside and they are coming back to do a 2-year thing, top-up to get the PharmD. They are given a project, and you go, what they submit to you, you can tell that, no, this was not done by him. Either they have a contractor or that ChatGPT thing, where you find that, in fact, I've seen it, every chapter has an introduction. Even the results section has an introduction. You go to discussion, there's an introduction. That, you see. So we need to take advantage of technology, work with all these people. They are our partners, and we have to know how to deal with them and be a step ahead. Definitely, there's something that needs fixing. And what is that? What is that? Is it fix yourself or fix the curriculum? You don't know. Well, whatever it is, you must get the right tools. the right tools? I suspect that the answer to this is both. We need to fix ourselves and fix the curriculum too, but we need the right tools. And this is what probably you mean when you said that we should have practical steps to design curriculum that responds to modern trends and ensures adequate practical training for graduates in pharmacy programs. We are seeking the right tools to fix this problem. It is my hope that by the end of tomorrow, we would have found the appropriate tools for that. You also propose in the theme, developing industry graduates through effective partnership. And that is extremely important, effective partnership. Okay. Conventionally, if you want to develop a curriculum, it starts with a needs assessment. What do you want to achieve? And that question must be answered. What do you want them to do? The roles, and then move from the needs to the competencies that are desired of the person you want to train, and use those things to develop a curriculum. We are not developing a curriculum. We have existing curriculum. So what we want to do is an assessment of our current curriculum. Is there a problem? And we need to look at it. So that's where we are there. So the reason we are all agreed that we need to change, but we are not changing just for the sake of changing. Change for the sake of change, no. Tracer studies, are you the one who mentioned? Yes, we say we want to change. Where is the evidence? Have we ever followed? Where are our graduates? How are they performing? What is the feedback from industry? All that we have is anecdotal, no data. It's important to do that. And then, when you have that, then we have a clear vision, which we must get together with our stakeholders. Where do we want to go? And we plan for that. I took this from the curriculum of the pharmacy program. There is a dean here. I'm sure it was done when Professor Charles Ansah was dean. This is what they say the aim of their program is. The aim of the program is to train highly skilled and competent professional pharmacists and pharmaceutical scientists of national and international relevance. What does this say? I'm not afraid to tell them it doesn't say anything. Yeah, to say that our aim is to train competent pharmacists. No. So, this is probably one of the beginnings. What do we really want to do? When we talk about reviewing our curriculum, we need to change our vision, and make it sharper so that we know where we are going. Otherwise, what is the difference between you and UDS, Central, UHAS, and all those other people training? We need a focus. And so, I said, I hope there is no disconnect with today's objective, which is that practical steps to design a curriculum that responds to modern trends and ensures adequate practical training. That will, listen, we need to align this with that, okay? And something, when I looked at this thing this morning again, the topic, that practical steps to design curriculum that responds to modern trends and ensures adequate practical training. I had already submitted my slides, and I realized I didn't know what they wanted. I said, how can you speak on something that you don't understand? My confusion was this. Response to modern tech trends, but ensures adequate practical training. I asked myself, what do we mean by adequate practical training? Are we talking about quantity, the number of hours? Are we talking about the quality? Whether the number of hours is enough, but we need to improve on that. What is it? Then to increase the confusion, I said, practical training. You can have another interpretation for it, which is realistic, be practical. So which of them do they really mean? I had already submitted my time. I said, thank God. But as I kept thinking, I remembered the chief thing. He said, you shouldn't look too long into a corpse's eyes. So I stopped thinking about the topic. I said, I'll come in any way. So here we are. But I'm sure that by the end of tomorrow, we will know, or I will know exactly what the topic means. But whatever it is, as I said, we need to review our curriculum. You are saying it. And we need objective things, objective evaluation of the curriculum. I have shown this one before at a meeting with you people at Kofridria, but something similar could be done. This is for pharmacy programs for different countries, and the colors represent different things. How many hours for therapeutics, how many for professional practice, how many for the pharmaceutical sciences, the enabling sciences, those things about what you call the soft skills, how many hours, and then you decide. If there isn't any one way, this is for different countries, and you will decide, okay, for us, we want to put emphasis based on this thing, we have not got enough hours. And so we need to increase the number of hours. If we are doing it, where are we going to get the time from? We have to do this within a certain time limit. So no matter what we do, I would advise that the competencies must be our focus. And I will recommend this one, the FIP Global Competency Framework, supporting the development of foundation and early year pharmacists. This is undergraduate. This one contains competencies that have been validated. I know the process, I was involved, and sent to many countries, members of FIP, and is this competence okay for you? And at the Nanjing meeting in China, these things were put together, and they're very useful. Have a look at them. And each section, like say, you have pharmaceutical public health, what is in it? Pharmaceutical care, what is in it? Organization and management, professional or personal attributes. It will be very useful. It's a useful tool. So, outside that, see, we are thinking about our curriculum. And the thinking is more or less like a SWOT analysis of the curriculum. It will allow us to reflect how much practical training do we really need? How much are we offering? And ask ourselves, is it quality or quantity that we're talking about? Yesterday, somebody mentioned a case. I saw one. I was in the pharmacy, and a student from Central University came to me with a letter. He's looking for a place for attachment. I accepted her, put her there for about 4 weeks. What she was asked to do, I don't know, and nobody visited and left. And we want to increase time for practical training. Is that what we mean? I hope that's not happening in Kumasi. Now, the other thing to look at is, you ask them, is our training, is it compliant with current trends? You have already asked that question, compliant with that. Remember that it should be contextualized. When I said, look at the global competencies for pharmacists, yes, we've done it. But when we bring it down like Dan later, we say we need to domesticate these things. Which is relevant? How do we prioritize them and get what we want? And in doing all these things, if we have decided that this is our problem, what is preventing us? And this is where, in your SWOT analysis, you do this thing called pestle analysis, which is important. It tells you about factors that are not within your control, but you have to know, like government policies, fluctuating currency. Those we don't know, but we should be aware of them. And then the involvement of partners will be useful there. They have, they will have answers to some of these things. When we've done this, then you plan the strategy. And what is the strategy? The strategy then involves a stakeholder engagement. And you are talking about involving partners. That is it. We need the partners. You have to involve them. We can't do this without them. Who are the stakeholders? Make sure in doing this, the linkages between regulation, practice, and education is not broken. We have to maintain that and work as a group together. And the stakeholders, don't forget, we are all stakeholders. The teachers, faculty, preceptors, technical staff, and all those. They are important. Governance, the regulators and policy people, they are important. And the big group, the community or society. That involves the profession, related professions, okay, students, civil society organizations, and health and patient groups. You need all of them so that the product that comes out at the end, nobody will say they were not adequately consulted. Okay? So this group particularly is very important. They are the rate-limiting step in all this. The culture change. Okay? Here, strategy will fail if faculty, staff, leaders, and students cannot engage in difficult conversations. And we need to change our culture, our habits, and mindsets. We don't have to assume, Professor Adenu said it, you have a PhD and you say you are a lecturer, and we are seeing. And some of us have got mindsets that are difficult to change. But that is where we have to tackle first. That's why I said, fix yourself first. Until we do it, then we can move the others. If we fix ourselves, we create an environment that is safe for dialogue, and there is mutual respect for the ideas coming from outside, and then they also respect us. That is very important. You cannot fix the curriculum if you don't fix yourself. I said that. Here, I am saying that even if there are problems, it is possible for us to get what we want. A long tunnel, but we will get there. These are the conditions the development people will use. Conditions precedent. The World Bank, conditions precedent. Debt exchange, and those things. All right? So, one, stakeholder engagement, very important. These are the partners. You need to have a clear vision, and we decide that together with our stakeholders. Destination, where are we going? And then have these milestones for monitoring and evaluation, because if you have all this, it will just be a curriculum and we'll put there. We want to be able to say after 2 years that we have made progress, so we need milestones. Know our limits. We have to be realistic. We can't get everything at the same time. So otherwise, you won't achieve anything if you don't know your limits. And the strategy should be jointly owned. Everybody is involved. It's our program. So I'm saying that this is the way we can move from classroom to workplace. And this is the way we will develop industry graduates through effective partnership. Thank you.
Thank you, Prof. Certainly, we need to change our vision and we need to make it sharper. So we will move to the fifth or the second presentation in the second session. We are still looking at curriculum. So our next presentation will be delivered by Dr. Samuel Yao Opoku. He's also speaking of curriculum innovation, practical steps to design a curriculum that responds to modern trends and ensures adequate practical training for graduates. Kindly permit me to introduce Dr. Samuel Yao Opoku. So Dr. Opoku assumed the position of Foundation Dean of the School of Public Health and Allied Sciences, Catholic University of Ghana in October 2022. Until then, he was the Registrar and CEO of Allied Health Professionals Council of the Ministry of Health from September 2017 to September 2022. He served University of Ghana also from 2009 to 2017 as lecturer and senior lecturer, and then head of Department of Radiography for 2 consecutive terms, as well as head of Radiotherapy Unit at the National Center for Radiotherapy and Nuclear Medicine at the Kolebu Teaching Hospital. He holds a Bachelor of Science and is in Radiation Medicine from Howard University in Washington, D.C. in USA. Master of Philosophy and Doctor in Philosophy in Radiography from City University in London. He also has a postgraduate diploma certificate in research and ethical review. He has served on several boards and committees of the Ministry of Health and the University of Ghana, as well as other public and quasi-governmental organizations. He is an external examiner of several universities and serves as an assessor for the Ghana Tertiary Education Commission. He is a member of the Board of Directors of the University of Ghana Medical Center, Legon, and serves on the advisory board of the College of Health Sciences, KNUST. Dr. Opoku serves also on the Expert and Technical Committee for the Development and Harmonization of Training Curricula for West African Health Organization. He has other roles, which includes Ministerial Advisory Board of the Ministry of Health, Expert Advisory Board member, I beg your pardon, of the Health Facilities Regulatory Agency, as well as a member of the governing board of the Baldwin University College, Accra. Ladies and gentlemen, kindly once again join me to welcome Dr. Samuel Yao Opoku.
Good morning. It's already afternoon. Okay. That's where the confusion is starting for me. So, if I'm following my big brother, Prof, you know what goes on when the anxiety level goes up. And also, when I heard the invitation, I was a bit confused because that was the time that I was existing for the council as a greater. And also now going to to academia. So I didn't know where, to stay the balance because the two, have some conflicting, rules. Because the regulator want to see fit done in the way, and then we also in the academia, we also have a way of going around, some of these things. So that was a challenge, but I think I was able to stay in between. So my topic, as Cynthia said, is look at, the allied health, programs in the country. And also the confusion is that when we talk about the allied health, we are talking about several, professions. So sometimes it's also very difficult, to stay focused, which of the professions that you want to. but I'll try and stay. So this will be the overview of the presentation. We'll first look at who the allied graduate is, and then what kind of workforce that are needed, and then the modern trends, as Prof has said, and look at how we can, develop very effective curriculum. And so for the definition of oral health, there are several definitions across literature, but I just want to limit what the Health Professions Regulatory Bodies of 2013, that's Act 857, gave us. And it says that an allied professional is a person qualified in the branch of health sector, which is complementary to allopathic medicine, specified in the schedule. If you look at that act, the schedule, I think that is the 18, lists several professions that fall under the category of allied health professions. So to go to the next stage, I'm saying that, as I already said, it's a broad group of health professionals, and they use scientific principles and evidence-based practice, one, for diagnosis, evaluation and treatment for acute and chronic conditions. Also, for health promotion, we are talking about health promotion officers, nutrition officers, environmental health officers, and then also apply administrative and management skills to support the healthcare system. So broadly speaking, these are the roles that allied professionals play in the health sector. Again, it varies from country to country, but generally speaking, in the health sector, you should find about 60% of the healthcare force belonging to this broad group of allied professionals, those in the clinical setting and the non-clinical setting. So my next question is, what workforce do we need for the health system? And the area speakers have, given a lot of this about what we need. And we are saying that the workforce that we need, the human beings are the most valuable assets that we need. We can have mansions, we can have the machines, we can have all the equipment, but the most important that we need is the human resources. And that is what the College of Health Sciences is there to provide for the country. We're also saying that the improvement in the global health will require universal health care support, with the right competencies. I think both Prof. Adenu and my senior brother, since morning, I've been mentioning about the competencies. Okay. And therefore, my question is, how do we produce the caliber of personnel that we need? That's the big challenge for all of us. I don't really have the answer to it, but then as we move on, I think we should be able to profess some of things that we can do to produce the people with the right competencies, people who are people-centered, people who can make the right decisions at the right time. A colleague this morning was talking about some issues from the lab. These are some of the things that as health system, we need to be very sure that we have the right people there and also making the right decisions to help the health system. There's also effective communication that has also been stressed over and over again this morning. Our communication with our colleague, working staff, and also even the patients that we serve. And now the focus is also evidence-formed practice. Gone with the days that people would just sit down and do things, But now we want to say, I'm doing this because of A, B, C, D. I'm sure that's what the clinicians, are now. And then we have people who have the right personal conduct. That's a challenge. Now you go to the hospital, you go to the ward, a nurse is doing medication, and one hand is holding the phone, WhatsApping. You know, the way we communicate about our patients on the corridors, in the nurse's room, in the medical doctor's office, are all issues that, as a country, we need to do something about it. So in preparing the future workforce as a college, as a health system, how do we address these issues that are facing the health challenge, the country? I came in when Prof. Denu was giving his presentation, and then he dwelt so much on the curriculum. I think that I was so thrilled about how, you know, he took the topic, you know, through. So my question again is, what is a curriculum? Sometimes we have different meanings. People even seek as a syllabus, which just talk about the content-driven, okay, and then the curriculum. But we are saying that curriculum is the competencies or the learning objectives or the learning outcomes that drive all that happens. So if we are going to talk about physiotherapy, and we are talking about physiotherapy curriculum, we need to have a curriculum that will address the issue of how to prepare the students, what kind of assessment we are going to use, what books we are going to use, what form of teaching is going to be applied. So that will form the basis of the curriculum. Okay. So at the end of the day, curriculum should be able to provide a planned, taught, and learned, or actual curriculum. That's what we need. Something that should provide the outcome, the learning objective, so that when students start from level 100, they know that at the end of the program, when I finish my program, this is what I should be able to do. If that outcome is not set, then the education is failing. Okay. And again, we also asked to look at modern trends. Modern trends in healthcare. We all know that things are changing and changing very rapidly, you know, in the health sector. There are 4 specific things that we need to do when we are talking about modern trends. We are talking about the specific competencies that also we do over and over again this morning. Then the generic attributes of the personnel that we are training, the theoretical learning, and the clinical or the practical practice. Because that is the end of the road. We are preparing people to go there and then to practice. Okay. So what we are saying is that the specific competencies are those relevant to each professional scope. Again, I said that in the allied health big area, we have different professions, and each professional group has a defined scope of practice. So whatever we are doing should fit into that scope of practice. And that is where sometimes the challenge is. In the academia, want to do their own thing. The regulators want to do their own thing. And then the employer also want to see some kind of, elements in the training. So how to marry this, sometimes also becomes a challenge. Then we are talking about patient care is central to all that we do. We need to have the patient as a focus for the training. And then the theory that is taught in the classroom should be learned through input from others as well from self-study. These days, we have self-directed study, we have group studies. Our students can go on various platforms to learn, provided for their learning, is relevant, and it also help, the course of our training. So let me narrow it down to curriculum for the allied health. Again, it has to have dual focus of producing profession-ready graduates and equipping them with future-facing capabilities required to adapt to responding changes in the health center. Whilst we are preparing them for today's setting, we should also be looking into the future. Because, as I already mentioned, things keep on changing. When we started some years ago, we were going to a dark room to produce X-ray films. But I think now that belongs to the history. Now we have the digital platforms where images can just be manipulated in a way. So we should also look at future and prepare our students towards what is most likely to happen in future. So the central point is also competency. We are talking about competency. So the competency is from the training that we are giving the students now to what they will acquire in the long run, so that they will be capable of performing. Without that, also there's no training. And the goal of competency curriculum is to ensure that we prepare students to be practitioners, not theories. We don't want them to go and you ask, they can remember, but when you ask them to perform, they are not able to perform. That is not what competency is about. So for competency-based curriculum, we are looking at first identifying the competence that are required. Together with the stakeholders, as we mentioned, we have the industry, we have the employing agents, and then more also the regulators. So this trial is also very important for us to define the scope of practice for each level of training. Okay, and then we put the competencies into teams. So if it is CT scan that you are going to perform, what are the steps that needs to be taken? What are things that are required? If it's MRI that we are going to, how do you ensure safety of the personnel, the patient, and also the equipment? So these are put together, in a theme for the curriculum. And then we organize the teams into courses, and then, of course, the courses into the curriculum. And then, most important, as Paul said, the evaluation of the curriculum, because it cannot be static. We need to review and review and review. So what we taught some years ago, now we can just turn them a cake, because they cannot stand the test of time. So continually, we need to review and review. Okay. Now, the teacher talks about, when we are talking about competency-based, we are looking at what is called work-integrated learning. And what that simply means is that we take the classroom to the workplace and then the workplace into the classroom. So if you are teaching the classroom, what you are teaching should be so practical. It should be the application of the knowledge, not the definitions and sometimes what, Prof said this one, discuss, We want to ask the questions, why are you doing this? How will you do this? So we are now bringing the industry into the classroom. And then when the students also go on clinical rotations, clinical attachment, we also want them to attach the scientific basis of what they are doing. Okay, so when these two are not connected, then we'll still have the challenge where people come, they are not performed. When they're in the classroom, they can talk like, but when you ask them to practice, then there's a challenge. When they're in the clinical setting too, and then they are doing something, you ask, what is the rationale behind what you are doing? Then they stand and look at your face. So we need to transfer the classroom to the industry, and also the industry back to the classroom. that is something that the work in together learning, sought to help. So quickly, let me take some of the practical things that probably we can look at when we are trying to look at producing the caliber of health allied professional that we need. We are saying that if we look at some of the programs that we run, especially when I was at the council, and also even when I worked for GTEC, you'll notice that a program will be loaded with essential courses, university required courses, and then just small percentage of this thing is allotted to the core competencies that will require, and that's something that we should take a second look at it. I know every university requires students to go through some courses, but we must find a very fine balance not to put too much weight as against what the profession specifically requires. And again, if you look at some of the programs, the technical or the practical courses, some even start at level 300. Well, the first 2 years will be the general courses that students do. So then they will have 2 years, to spend on whether it is physiotherapy, whether it's medical lab, whether it is medical imaging, and that has been found not to be very, very helpful. For some programs, for the 4-year, we require that a minimum of 1,200 clinical hours, should be able to provide the required competency that we are all talking about. But I must quickly add that what is important is not the clinical, the period, but what we do with the time. Because again, students go on internship, they go on attachment, some become errands, some become office, personal assistants to the people that they are supposed to be working with and supervised and supported, and we could still have the 1,202 hours, but that will not be very effective. So the time, the hours have been provided as a guide, but again, the most important thing is what we do with the time. And we're also saying that both the curriculum should, and then the scope practice, and also the job description, there should be a synergy. And these days, some of the programs, we have the curriculum separately, and then the regulators will also come with the scope, and then the employer will also, the HR director will also sit in the office and develop the JD, where there is, most of the time, some disconnect, between. So these three, the curriculum, the scope of practice, and the JD, there should be a synergy. And again, for the clinical placement, we think that law books should be properly utilized. Again, that's something that some of our colleagues in the clinical setting are also not helping. They allow the interns to do whatever they want to do, but at the end of the day, they will come with very good assessment, some 90%, some 80%, depending on how, close, the intern, is with the preceptor. And that is not the way to go. And then there's also a school of thought that for some universities, the pass marks for most of the courses are either 60% or 50%. But then for the clinicals, the suggestion is that anything between 60 and 70% should be able to adequately assess whether the people have the competencies to go up there and practice. So to conclude, we are saying that we should move beyond educating for competency to capability. That's the ability to adapt to the change, generate new knowledge, and continuously improve their performance. So competency is fine for today, but then we should be able to prepare our students so that they will be very capable also to look into the future and adapt to the changing environment. And the programs must be designed to ensure that future professionals are equipped with the challenges of the modern healthcare. And changes in the healthcare system require a focus of attributes and generic competencies of health professionals. And we need to focus to better fit into both the academic and then the professional world. And last but not least, to develop interprofessional patient care. That was a point I think Prof mentioned, that this is nurses, this is pharmacists, this is doctors, this is medical lab. There's no coordination. So when they meet at the clinical setting, like people are very comfortable in their area of this thing. That is something that, as we move forward, we should be able to tailor our curriculum to make sure that interprofessional collaborative work. On this note, I want to end here, and thanks for the audience. Thank you.
Thank you very much, Dr. Opoku. So, being a College of Health Sciences, as we learned last week from the Biennial Conference, we don't want to sit for too long and not stretch a little. And this one, I know I said in the morning, these are very senior members, but Provost has given me the permission to let us just exercise our lower limbs to our legs, and then our hands, our upper limbs. So if we can just, yes, if you wouldn't mind, I'll be grateful if we can stand up. I appreciate that these are very senior members. So if you are unable to stand, we understand. But if you are able, please stretch. Yes. It's been a very long day, but I think we've done very well. Thank you so much. We haven't finished though. We are now coming to the teaching where the problem is. So please, last round, you know we are a very big college. So we have to try to cut across. We can't leave any school behind. This is very important. So kindly come. Let's see how we can break the silos and begin to work together. There's this advert, I want to issue a disclaimer. I'm not advertising for any organization, but so there's an uncle and a niece, and he says, uncle is saying, oh, ask any question, I will teach you. Then he says, okay, uncle, teacher says I should write how to prepare your favorite meal. So, uncle, what is your favorite meal? Then he says, apapransa. So, okay, uncle, let's start writing. So, oi, you better running na teacher for pad. Homework biya no mudiama. Please, just write how to prepare chocolate drink. Just add water. So, we've all been students before. Sometimes the assignments we give to the students, I can imagine they'll just be saying, Dr. Kwatin pad, assignment biya no diama. But sometimes we shouldn't do the easy one. Chocolate drink is easy, but it may not help us achieve the aim that we want our students to have. So finally, we are going to look at innovative teaching and instructional strategies. You know, we've heard that the students are advanced, they are ahead of us. How can we improve the way we teach so that we will be ahead of our students and we will always appeal to them. The big challenge, 40% attendance, 60% attendance to classes. How do we change the rhetoric? So our last speaker is Professor Sebastian Eliasson. So I was reading his profile, and I want to just limit myself to the teaching, but I was also attracted to the part on winning the big grants in the way. So please allow me to introduce Professor Eliasson. He's an associate professor in population, reproductive, and child health, a fellow of the Royal Society for Public Health, and a medical technology engineer. Wow. He's a proud product of St. Augustine's College, Cape Coast, University of Ghana Medical School, School of Public Health, University of Ghana, University of Cape Coast, and St. Bartholomew, and the Royal London School of Medicine and Dentistry. Okay, let me skip to the teaching part. He's an experienced university teacher, ethically sound industry leader, and community health improvement advocate. He has trained medical doctors and mentored young faculty to access programs in medicine and public health, and has built competencies of Ghana's reproductive and child health workforce to deliver quality care to clients. He's highly driven in his research interest area, mainly maternal, child, and adolescent health and family planning. He also has considerable interest in health systems strengthening, medical technology, and disease control, as well as prevention. Prof. Eliasson secured a UNFPA funding of 2.5 million. You know, that's what academia wants to hear. So please let me mention it. $2.5 million to support Ghana's reproductive health commodities stocks during the period of the GAG rule in 2007. This singular effort prevented an imminent shortage of contraceptives and other commodities in Ghana. He has supported DRIC to secure funding of nearly $900,000 for baseline studies to improve maternal, child, and adolescent health, as well as nutrition in the Upper East, Northern, Upper West, and Upper West regions of Ghana. Prof. Eliasson is also well written. He has 30 publications to his credit, including in peer-reviewed journals, articles, technical reports, and abstracts. He's an astute academician, a college administrator, has passion in building capacities of the next generation and the health workforce to help strengthen the health systems in Ghana. Ladies and gentlemen, please help me welcome Professor Eliasson.
So good afternoon. I believe you are all tired. And but I still have to come. Because I think the first time the provost called me to come for this program, I told him I will not be able to come. I wanted to swerve. And then he didn't appear again. Now, the next time, Professor Ameni Dankwa appeared. I mean, when the women appear, you know you can never say no. So she kept on, you know. There are times I decide, no, let me find somebody to come and do this because I'm too busy, medical school exam here, all the pressure. And then she kept on, you are there, and then she would send a WhatsApp message, this woman will stop. So I kept on. And then, as if it wasn't enough, yesterday, another person like Ivy Boatin, Dr. Ivy Boatin also appeared. I said, are you here? I said, I'm on my way. Even as yesterday, I was planning to swerve, but when she appeared, I said, hey, this woman won't let me rest. I need to come, you know, so I'm here. So, but what we are going to discuss today is extremely important. And I believe that all of us have struggled through, how do we deliver the content? And so this is just an outline. So you see, so we need to go back. To be able to understand all this, we need to go back. The further backward you can look, the further forward you can see. This is according to Winston Churchill. Okay? So we need to look back a bit. There is this guy called Abraham Flexner. I don't know how many of you have come across this guy. How many of you know him? A lot of you know him, right? Yes, he's an American educationist who set up, his own preparatory school. He taught at a lower level. And he was commissioned by Carnegie Foundation to look at the medical schools in the United States and Canada. He wasn't a medic, he was an educationist. So he was to look at. And those days, medical schools were standalones. And because, he said medicine is an art and a science. But they were practicing more of the art, So if you know, surgeons, for example, was Mr. Something. It was all apprenticeship. So those days was standalone. They were practicing, teaching them through the art, and so but very little of the science. So after reviewing all the medical schools in the US and Canada, he made some recommendations. And some of the recommendations were that, that he made had consequences. So about 50% or so, over 60% of all the medical schools were integrated into universities or closed down. So you had to integrate or you close down. So you needed to integrate within a university or you shut down. And then medical school curriculum became academically entrenched in basic sciences. So that's where all this started, in basic sciences. And standards for hospitals' care were developed, improving patient care and outcomes. Teaching hospitals emerged also. Does that concept of teaching hospitals also emerged? Only a few medical schools remained opened that predominantly trained, but those are the criticisms that came with his, so the black and the minority schools were closed down virtually. We were left with just two, Howard and another one. Okay? And then setting up of NIH and huge research funding to medical schools with research positions for basic scientists. So there was some motivation for basic scientists, and that was the birth of the traditional method. And I believe a lot of us were trained within the traditional methods. KNUST, UG, UDS also tried some innovative, but it really didn't work well. And all of us, virtually, so the traditional method of teaching, we all went through it. And so of course, but we know what it is. It's more teacher-centered, subject-based, hospital-based student as a passive participant. So, what was it? There were some criticisms. We were taught benzene ring, for example. The structure of the benzene ring. How was I going to use benzene ring to manage a patient with kwashiorkor, for example? We kept asking, but we needed to understand, draw it. And so criticism came. The traditional curriculum is seen as reflecting disciplines with a vast amount of content, which could be a passing parade of insubstantial content. Who are you to go and complain? The teacher is there talking to you, teaching you. Take it or leave it. Memorize it. And then whether that content could solve a problem or not, who are you to talk? Because you go and talk and you say, I'll fail you. And that is it. See, the traditional curriculum tends to be a mixture of the wishes of the various participating faculties, occasionally with content bordering on the rare and distant frontiers of science, often too rare and distant to be necessary for inclusion in a curriculum design. necessary for medical practice. Talked about benzene ring. Who are you? So rare, but whether you liked it or not, you had to stick to it. Let me use, then we move to innovative teaching. I'll use the story of University of Cape Coast. In the mid-1970s, you know, UCC also wanted to set up a medical school, and they were going in that direction. So in the mid-1970s, the Vice Chancellor then, Professor Joe Yane, he predicted that, so maybe if there was a science faculty, yes, so if there was a hospital built in Cape Coast, a regional hospital, then UCC can set up a medical school. So because, you know, Faculty of Science, the traditional already in mind. Professor Adobin came, 1998. Regional hospital in Cape Coast was put up, now a teaching hospital. 2003, he set up a committee now to look whether it is possible. So they actually developed a proposal. They passed it through NAB, NCT, they got accredited. They were about to take off. Of course, these were scientists. So this was going, the medical school was going to be based in the Faculty of Science. And so they now employed the dean, the founding dean, Professor H.S. Amonu Kofi. He was in Saudi Arabia somewhere minding his business, and they brought him. Come and lead this medical school. So he got in and said, let me look at your curriculum. He looked at it and said, no way, I'm not going to go in this direction. Accreditation has been given. He said, I am not going to go with this. So you either let me have my way or I go back to Saudi Arabia. So he was prepared to leave. So they said, okay, do your own thing. So that is when he decided to introduce the innovative curriculum into UCC. Okay, so that is how it got all started in UCC. And then, of course, in 2008, the first batch of students were admitted. What were the reasons for the shift to innovative curriculum? I mean, then, these were very relevant reasons. Current far-reaching changes in the working lives of physicians, fast medical progress, changing demands of society, and patient needs, as well as new findings from educational research were reasons. Traditional discipline-focused medical tracks limited in how well they prepare graduates for their working lives as physicians. Criticism focused and a lack of competency training in the areas of practical clinical skills, physician-patient communication, teamwork skills, and scientific skills. These are things that we have been talking about the whole morning and part of this afternoon. Students and graduates feeling insufficiently prepared for the demands facing them in their working lives as physicians. You know, these are very relevant. So these were reasons why the traditional methods were not working. And therefore, we needed an innovative way of thinking. And so, the innovative teaching was born. Okay, we went in that direction. Of course, it started earlier. Some schools in the US and Europe had started it in the 1960s, thereabout. And it started very late in our setting, at least UCC started. And innovative teaching defined is more student-centered, problem-based, community-oriented, competency-based, outcome-oriented. It's integrated. And then, of course, it has early clinical exposure. So those are the tenets of innovative teaching or curriculum. So it has all these components. The integration, I'm just using this, as you can see, a horizontal integration, and of course, a vertical integration as part of the integration. But all these, of course, sit in philosophy. They are all grounded in philosophy. So let's look at the roots within the philosophy. See, and it traced to Socrates' time and Aristotle. So Socrates used problems to engage students, thus helping them explore and appreciate the inadequacies of their preferred solutions. So it was all problems, getting them to think, and then interrogating their solutions, engaging. So it makes the students think. So it started so many years ago, at the time of Socrates and Aristotle. But of course, in modern days, it is grounded in progressivism, constructivism, and humanism. So let's look at first progressivism. Progressivism is a pragmatic philosophy, and it emphasizes these hallmarks: experiential learning, scientific inquiry, community involvement, and responsiveness to social problems. John Dewey was one of those who led this kind of thought. Constructivism, Piaget. So this was concerned with how we come to understand or know. And he says knowledge is perceived as not absolute, but constructed by the learner according to what is previously known. So when you have a problem, you need to know, do I know something about this? Once you do that exercise, you're able to establish a gap. So that gap is what then drives you to look for more information to be able to solve the problem. So that is that constructivism. That is that philosophy that drives that kind of thought. Humanism contains that learners can be trusted to find their own goals, set their own standards, and evaluate their own progress, develop positive relationship with peers. It builds on adult education principles. For adults, they learn what is relevant. They learn at their own pace. They don't want too much. They will learn what is relevant. So they build on their previous experiences, and it's participatory, problem-focused, designed to increase personal responsibility for learning, immediately applied in practice, and based on mutual trust and respect. So what is the end goal of all this innovative teaching? Is to build competencies and skills. Trailing and Fidel have, discussed so much about this, what we call the 21st century skills that we need to acquire, that our students need to acquire at the end. And this makes, once you're able to acquire these 21st century skills, it makes you a lifelong learner. It makes you, and that is what present day industry wants. Your ability to even adapt to the changing world. So what are these skills? So they are grouped into three: learning skills, literacy skills, and life skills. So if you look down there, I'll put it as an equation. So the first is the learning skills. It's 4 C's. Critical thinking is key. Critical thinking is key. The ability to solve problems when they arise. Creativity. Collaboration. Communication. These are the learning skills that one needs to acquire to be relevant in industry and to the changing world. So those are the 4 C's: critical thinking, creativity, collaboration, and communication. Key learning skills that students need to acquire, and which are demands of innovative teaching or curriculum. The second is the literacy skills that we need to build, and that I've called TIM. So you can see FORCE TIM, 4C, FORCE TIM, if you want to remember. 4C, so 4C is force. FORCE TIM, technology, information, and media. So present day, we need technology to be able to operate. We need the information, relevant information. How do our students look for the information? Using technology. There is media, social media, and all sorts of media outlets. How do they make use of all these media outlets that exist to be relevant within this changing world and in industry? The third is the life skills. Very important. And that I've called flips. So forced him to flip, and then he gets 12 CDs. So if you forced him to flip, he gets 12 CDs. So what I'm saying is that there are 12 21st century skills that you need to build. But if you want to build it, you must force him to flip. Okay? So the first is flexibility. How flexible are you to a changing environment? How are you able to adapt? Adaptability. How flexibility. Are you able to change with the changing working environment? And how are you able to adapt? Leadership. You need that skill. As you grow in the industry, you need to be able to lead for results. Initiative. How innovative are you? How do you market new ideas? You need to have that initiative to be able to do that. How productive? You need to be very productive in this modern day. You can be there and you are just there, receiving salary, but not productive. And then the social skills, very important. Social skills, soft skills that we talked about earlier in one of the presentations. Those soft skills, how do we? So these are the skills that industry expects that our graduates acquire, skills and competencies. And this is it. Force him to flip for 12 CDs. So what are the innovations that we need to achieve these 21st century skills? And these are the things we apply in the University of Cape Coast. So now we started by not doing subjects, anatomy, physiology, we didn't start that way. UG, where I trained, is anatomy, physiology, and that's it. You memorize, you go and write, and that's it. You jump. That's an H structure. We call it an H structure. After that, it's called a preclinical. Then you hop to the clinical space. And then you continue. Hey, I'll fail you. Then they fail you, and then you go. Nobody even talks to you. Hey, you see your lecturer, you see here coming this way, and then you take the other corner. We're so scared of the system. You just have to obey. They say it, and you say, yes, sir. Even if the master is wrong, you say, yes, sir. You are not allowed to express, what you know. So you take it or leave it. Okay? Because the traditional system teaches you. So they give you the information. That's what the traditional system did. They give you information, you memorize it, and then you use that to solve a problem. But the innovation system is not like that. You start with a problem. You look at the problem, what do I know about it? Prior knowledge. Gap established. Look for further information and solve the problem. So that is what it is. So we started using a system-based kind of thing. We have a modular system, an integrated system from the very beginning. Okay, from the very beginning. So you have horizontal integration at that level, where all the subject areas, so if you have a respiratory module, for example, okay, you have everybody, anatomy, physiology, and even the clinical areas contributing to that module. And at that level, you have a practical section infused into it. That is the simulation bit. Okay, so you introduce the practical, the clinical, skills very early in their training. So that is what we call the spiral kind of So that's a vertical integration. So you introduce the clinical competencies early by way of simulation. But then there's a horizontal integration where all the subject areas come together to deliver a module. Okay, so we have also the problem-based learning as another tool, and the clinical skills, of course. And then we have also the community-based experience and service, which we will talk about. So for the modular, so to say a module is an instructional unit within a larger course or curriculum, usually organized by chronology, topic, or theme. Each module is designed to achieve specific aims and objectives. And they are usually integrated horizontally, that is across different subjects, or vertically across various years and levels. Modules are managed with the use of module coordinators and module guides. So for each module, we have module coordinators and we have module guides with objectives and competencies that ensure that we are building the 21st century skills and competencies. Okay. Each module is evaluated separately. So if you look at, for example, we don't talk about preclinical and clinical level. We talk about cycle 1 and cycle 2. So in cycle 1, for example, as an example, we say we have MED 205, which is musculoskeletal system 1. And at the cycle 2, you see that there is musculoskeletal system 2. Okay, so the system 1, for example, has all these anatomy, basic science, anatomy, physiology, all integrated into one, with the clinical people also contributing the clinical significance of what the musculoskeletal system is. And the practical bit, we use the simulation to do that, to introduce them, to get some hands-on practice clinically. Anything that has to do with the clinical experience. It's introduced at that point. Okay, so that is how the modules are designed. So we have 1 and 2. Okay. That is the module. And then the problem-based learning. So the problem-based learning started way back by Case Western Reserve University. They used more of the hybrid system, which we do also, because we do teaching. We do some teaching, but in the form of modules. Okay, and then we add that other part, which is the problem-based learning, to support. But the pure problem-based learning curriculum was pioneered by McMaster University. So it's a pedagogical approach which uses cases and problems as the starting point for acquiring the desired learning objectives. And teacher is just a facilitator. This time, teacher is not the main focus. The student is the main center, and they drive the process. Okay? So usually, what happens is that we start with a problem. So they are usually 2, let's say 3 sessions. And then what we do is that we divide the students into smaller groups. And each group elects their chairperson, they have their secretary, they have their timekeeper, and they have a scribe, somebody called a scribe. And the teacher is just a facilitator. Okay? The learning objectives are with the facilitator. He's just guiding them to ensure that they're actually achieving the learning goals without occasionally giving them a clue on which direction they should go. But he's a very passive, person, part of the process. But the students are active because there's a chairperson who drives the conversation. So they usually are given a problem, which is more also very integrated, okay, as opposed to the other one where you start with the information before the problem. This time you have the problem. And then what they do is that they meet the problem, then they decide, what do I know, the prior knowledge about the problem. So they brainstorm. There's something what they call brainstorming session. So they brainstorm about the problem. Do we know anything about it? Okay, prior knowledge. So then they look at it. The first time, well, we know a little, we don't know. So then they develop gaps. So before they go home, they would have established learning objectives out of the problem. And also based on their prior knowledge, they establish learning objectives and take them home. So that is the first meeting. So they go home. And then they go and look for more information, using the technology and everything that they have. So already we are teaching them leadership skills. We are teaching them collaboration. We are teaching them communication. We are teaching them technology, because they need to use technology. We are teaching them information, how to look for the information. Media, how to use social media and all sorts of things to communicate, to peers and to their lecturers already. We are teaching them all these 21st century skills already. They are learning them through the problem-based learning. So they go and they come back. Second meeting, they come and then they try to solve the problem. So then they say it's gather information, share. So that's what we've discussed. And then they determine whether they have probable solutions. So then with the information they have gathered, they try now to see whether they have solved the problem or not. And that they do during the third meeting, which is a broader forum where you have content experts. So they come, the students come, and then they do a presentation. Okay, they already do a presentation. So they have everybody, every student, whether you like it or not, by the time you exit the school, you would have had your turn. So they do a lot of presentations. So if you look meet any UCC graduate, they are easy. Come and tell them, come and do the presentation. They wake up, they can prepare slides in 2 minutes and come and deliver. Because it's something they do. They do every week. They do every week. Prepare a slide. Sometimes in my teaching, like Prof. Adanu said, sometimes, especially when you know you haven't even prepared for a lecture, the dean, so you have a lecture with you. I say, okay, all right, I appear. What do I need to teach you today? So and so and so. Okay. Can you divide yourselves into 5 groups? You go and discuss this bit. Go and discuss it. Go to the library. I'm giving you 15 minutes. Go to the library, develop your slides, so and so, try to understand the concepts and come. So I come and sit in as a facilitator and I listen. They will deliver in 15 minutes. And the ideas they bring back, you wonder, how did you do all this in 15 minutes? But because you have challenged them, and the kind of things they do is so interesting. But when you come and they know you are coming to give them a lecture, they come and sometimes sit and they sleep. They stop thinking because the slides from the previous years are there. I mean, why? They only sit in because probably you are the dean. So if you don't come, there will be some punishment. But they come and sit there. Some are sleeping, and they are there. But then when you challenge them, they are able to, use all these skills that we want them. They do that. They do that because the PBL and all those other things have exposed them to some skills that they can use to do that easily. Okay, so that is the PBL for you. That is what we have been doing for a long time. So PBL is resource intensive also. It doesn't come free. It is resource intensive. I mean, sometimes we buy flip charts, we use boards and markers and all sorts of things. And you need to train, you need to have adequate faculty to be able to facilitate. And you are doing this 3 times a week. And so lack of resources can actually destroy the program and the ideas that you have. And sometimes the drawback is that when you teach the traditional methods, we are also role models to these students. So if they don't see a role model, they lose out because PBL, sometimes it is not an expert, subject content expert who is a facilitator. It can be somebody who has no idea about the subject, but who is a facilitator? Just listening in passively and trying to guide them. Okay, so they lose that sense of, that role modeling that they desire. Sometimes they tell you, but we've paid so much school fees and you are not teaching us. Now we are doing the learning on our own. So those are some of the drawbacks, And so that is it about PBA. The other one is the community-based experience and service, what we call COBIS program that we have. It's another tool that we use to deliver our content so that they can also build the 21st century skills. Okay, so that one also has a coordinator. I coordinated this program for almost 4 years, and it is not easy at all. So we have sites in the communities, and it's a flagship program that we have. And it's a student-centered, problem-solving, innovative, community-based, strong community orientation, increases the awareness of the social, cultural, and environmental factors in health. So those are the things that this program teaches the student, and teaches them the relationship between health and development. So sometimes in our exam, you tell them, can you draw a graph showing the gross domestic product and maybe a health indicator, for example, and they're able to draw the curve for you because they understand the economics and they understand the indicators of development. And so they're able to do all those linkages. Okay, so these are some of the things that, so we have usually who is eligible for this program. Level 100s, they do all these preparatory things, so we don't include them in that program. And level 600, because they are busy now preparing for their exit, we don't also bother them. So from level 200 to 500, 200, 300, 400, 500, 4 years. Every year, you spend a month in the community. Every year. So once you get to level 200, you spend a month. This is not community medicine or community health. So the community health program has its own community engagement, and this is run from the dean's office. And facilitators come from geography to wherever. Nursing, med lab, medical school, anatomy, everybody is a facilitator. You don't need to be a community health expert to be a facilitator on the field. Okay, so this is run from the dean's office. It is different from community health. So this is a standalone program. So as I said, everybody can be a facilitator. And usually we spend 1 month in the communities. And we have themes. So level 200 has their theme, level 300 has their theme, level 400 has their theme, level 500 has their theme. And these are fixed. So level 200, when they start, that's when they are starting. They start with the social, cultural, economic, and environmental determinants of health and disease. So for the first time, that is what they go and do. They learn about the community, the social structures, the cultural issues, the economy of the district, the rural area that they are assigned to. And then they link the determinants to health. And then level 300, the theme is aligned to the World Health theme. Every year, the theme changes, so we align with it. And level 400, the general theme is on gender, maternal, and child health, and HIV/AIDS. So that one is fixed. But then we align it also to the World Population Day, okay? Or any gaps in all these maternal health and HIV/AIDS family planning, any gaps that they have. So if it's the World Population Day theme is not too relevant, then they establish gaps and they run with it. And then the last one, level 500, because they are about to exit, they need to understand the health system. So their theme is health systems management, leadership, and communication in provision of quality healthcare. In that one, we send them to the districts. The district health service, they work with the district directors. They actually go down there. They move through accounting, human resource. It's not only hospital-based. They do go to accounting, human resource, laboratory. So they go everywhere. So by the time they leave that space in 4 weeks, they know everything that the district does. They understand the district problems. They do everything. They say they have a total understanding of what the district level is. So that is at level 500. Okay? And the field implementation. So they go there, we set them out, we select communities for them, and then, of course, they do an entry. They do a deba, big deba. They introduce their theme, their objectives, and whatever, and then at the end, they also do a deba and give them results. And these things, in fact, sometimes you can have a student who has never seen all this before, who has never even spoken Twi before. I mean, they speak the broken Twi, but after 4 years of going through, they speak fluent Twi. Some are so shy that, I mean, if you say, go and stand before this group, they say, no, say I can't. I say, yes, you can. And then the way they deliver, sometimes you get chills. They say, this is somebody who say, I cannot. But they start and it's like, wow. So you could, indeed. And these are things that change the mindset of our students, builds confidence, So all these things that they do are giving them, because when we set them out there, they select their own leadership. We have everything. All the groups have leadership. Okay? So within this community, they do research. They provide service. They live with the people in that community. They buy their food. They get the diarrheas that the people also get. So I tell them, go with your Cipro and your metronidazole. Eat their food. Understand where they come. So that when you sit in your consulting room and they come to you, you really understand where they are coming from. Okay, so when they are talking to you, presenting their symptoms to you, you are not busy writing. You are sitting down listening to them. Because you know where they are coming from. Okay, because you have been trained to listen. So there are impacts. It has improved research capabilities, increased appreciation and deeper understanding of factors involved in health and disease, increased appreciation of disease trends and characteristics of different, improved competencies in investigation of diseases, ability to live and survive in hardship areas under hardship conditions, develop good team players capable of functioning in any group dynamic. So sometimes when we go, I go there myself. Something we call by the fireside. So every year there is something like that before the exit. We do a bonfire, and then I'm the leader. We all dance around it. We are all dancing. All the different groups. You play your song, and then we all dance. And it's just to build the team, a team spirit. Okay? It's a good team building effort. So we increase leadership competencies, improve report writing skills. So when they come back, there's a forum where they post their pictures, we score them, they do presentations, and then the winner, we throw a party for the winner, and then the last person. So the party is not for only the winner, it's the winner and the last boy. So just to encourage them. So that is how it works. And of course, the impact on the community is also very massive. Now, the simulation skills, I've spoken about it. This is what we aim at, the high end. But we start with a very basic one, because this is the future. The future is that at one point we may not get patients, and we need to simulate. In St. Bart's, where I trained at a point, when training anesthetists is so beautiful, you have 2 theaters, one fully equipped. In fact, both are fully equipped. This time with simulation, this one is real life. And there's just a door in between. So they train you with simulation. They're so seamless. When you are so perfected, you just walk through that door, and it's so seamless, and you are just functioning. So simulation is very good, and that is what we are trying to get to. So we introduce simulation very early in their training. And then as they build on in cycle 2, of course, the clinical itself, the real clinical work starts, but we still complement it with simulation. So that is also key. So that is where we are. And of course, the assessment. Cycle 1, we do all the essays, but the essays we start, formation. We give them essays during the period so that they can perfect. And then, of course, multiple choice, the end of summative exam, we have essays, MCQs, and then we have something we call objective structured practical exam at the lower, from level 200, okay? So we set practical exam. So just to understand what they have learned practically, hands-on, what they have actually. So we start early. So it's like a clinical exam, but this time using simulation. Okay, and then of course cycle 2. And usually when you fail the OSCE, you have failed the exam. If you fail the OSCE, you have failed the exam, because the emphasis is on practice. So that is what we do for evaluation. And then of course, we look at Bloom's taxonomy and we try to look at the high end of it so that they could think. These are thinkers that we want to grow. So I think that is it. Thank you very much. I hope that's it.
It's been a very exciting day. We've learned so much. We want to quickly go into the second question and answer session, and then we would finish for the day. I also want to say that we are not ending today. Tomorrow is still ahead of us, and we would go into the announcements once we complete the question and answer session. So please, I'll invite the facilitators to kindly come up stage, and then we'll take the question and answer session.
Okay.
There's some hands. Ushers, kindly help with the microphone. Dr. Singh, I've seen your hand. I'm coming.
Usually at this time they are tired. They want to leave.
We'll take Dr. Singh's question. Please, your hand up, sir.
Good afternoon. My question goes to Dr. Opoku. Dr. Opoku, it's a concern and at the same time it's a question. With increasing digitalization and adoption of information system in health industry, how do you see artificial intelligence in the diagnostic market dynamics affecting your future curriculum and training of the future industry? Thank you.
We'll take the second question and then would allow Dr. Opoku to answer. Please, kindly bring the microphone to the second row.
My question goes to the Dean of the Medical School of UCC. Can you give an indication of student numbers that you handle for the last 5 years and how it has influenced the way you run the learning systems? Thank you.
Thank you. Can we take one more question and then we'll allow them to answer? Okay, to say hand.
My question goes to Professor Eliasson. I want to find out what challenges have you had so far with this novel or innovative system that you have, and how has it been compared to the older, more structured system so far?
Thank you. So we'll allow them to answer.
Thank you, my young lady. The issue about artificial intelligence and particularly diagnostic imaging is something that has come to stay, and that is where we need to focus. The challenge now is how we can have that strong foundation to prepare students from the beginning, but then to appreciate the role of artificial intelligence in modern way of diagnostics. So it's something that should be happening, and I want to believe that the new programs that are coming will look in that area as we move forward. Thank you.
Thank you, sir.
Yeah, thank you. Let me take this one. In fact, we started with 42 students, very small compared to the traditional UG, KNUST. So the numbers were small. It was easy to manage. But over the years, the numbers have increased. Now we are managing about 160 or so per class in level 400. Okay, so of course, delivering a PBL, for example, will be very challenging. And so what we do is to complement the face-to-face meetings with online. Okay, so we are using technology to solve those challenges of numbers. Okay, the other issue when it comes to community-based experience is also the numbers, accommodation. Okay, so where we are, we have now, where we send our students, we have our own accommodation. So we have, it's a very old structures that the Ghana Consolidated Diamonds used to occupy in Achimansa district, a place called Ejubwe. So they gave those places to us. In fact, we have negotiated, we are paying for it. So we have several structures, dilapidated structures that we are refurbishing. So we've refurbished quite a number. With increasing numbers, we are now refurbishing more to accommodate, the increasing numbers of students. These are resource intensive, okay? And that is why our school started as a fee paying, so we are able to absorb some of the costs directly. But for you, I think you're also moving towards fee paying, and so you can handle it. I know your numbers are larger, but if you want to do it, you can still do it. All you need to do is also do some level of resource mobilization, probably outside the school fees, to be able to, because you are now starting, okay, you'll be able to handle it. So that is where we are coming from. Clinically, we are also going out of Cape Coast. Now we have an MOU with all the hospitals. Efiam Kwanta, the Catholic hospitals are around. We have MOUs with them. So we are sending our students out to do clinical work in those places. So that means that we are running all our modules first, and then the clinicals, they go without any problems. They don't have to look back for a lecture or anything like that. So that is what we are doing now. For the challenges comparing the traditional and then the innovative system, the challenges mainly, as I said, is more of the resources, human resource, and so on and so forth. The human resource, the financial resource, the material resources. Traditional, we didn't used to do, because these are people who are doing a month every year, apart from even the community health rotation. So it's resource intensive, okay? So we can't compare the two. There was no community-based experience in the traditional methods. But if you come to compare how effective these have been, I would say this innovative system is able to build the 21st century skills better, and it makes them lifelong learners. And that is what industry is able to bridge, that academia-industry relationship better than the traditional system, okay? As Prof. Adanu said, you can actually go for a conference and a very smart, traditionally trained doctor will not speak. They will be there and be hiding. But for these innovative ones, you are there and they will come to you. They want to network. They are doing all sorts of things, that the system, innovative system, has trained them to do. So I think this is a very good system that we need to run with. Thank you.
Thank you very much. Okay, so we'll take two more questions, and then we'll wrap up.
My question is directed to Prof. Ellison. Thank you for the wonderful presentation and the work that you are doing in UCC. I wanted to find out, I know that the medical school curriculum is very packed. And when you're presenting, you said you take 1 month to do the community-based approach, aside community health. So I was wondering how you're able to meet the demands of the packed medical school curriculum with the 1 month out every year.
Yeah, so thank you very much. As I said, the community-based experience and service is also a tool to build competencies. So is the problem-based learning tool, and so is the teaching tool. So we have the module that we do didactic teaching on. So if you look at our timetabling, for example, you see that the teaching is just an hour or 2 hours in a day. So the rest is either a problem-based learning or something practical that they have to do, okay? But there is time. We have actually scheduled it such that within the year, academic year, though our academic year is longer, far longer than the university academic year. And that is what our system has been for so many years. That's how it started. So we are able to accommodate that 1 month, you know, and community health is also is another module that is accommodated. I mean, the way we have our year, academic year planned, we're able to accommodate. I don't know how to explain it to you, but the way it is structured, we're able to accommodate. In fact, last week we had to even revise it even further to be able to, you know, shrink it, because we've seen that if we run the modules concurrently with the clinical work, for example, we don't have time for holidays. But now if we decide to run just the modules first, you know, and then allow time for the clinical, we'll be able to actually increase the contact time for the clinicals, and then also have some time, you know, to take some holiday. So that is depending on, you know, what we are trying to achieve, the objectives we are trying to achieve. We manage the time appropriately. I mean, you will not be able to appreciate it. It is only us who will be able to do that.
The last question.
Thank you very much. To Cape Coast again. And I've had the opportunity to examine your final year students, and their kind of confidence level is very good. That is a positive for you. But my question is, have you had a tracer studies on your graduates, comparing them with the traditional system? Thank you.
All right, so we are yet, in fact, we are now building the database for our alumni. So over the years, we haven't done well with the database. So right now, we are seriously doing that. We have an office for them, and we have asked each group to select a leader. So we have started now building the tracer, building the alumni group. And then once we have the contacts, we'll do, you know, but already casually, for the first batch of students, okay, almost all of them, apart from just 1 or 2, have specialized already. The first 42 that we took. For the second group are also on the way. And the good thing about our students is that, in fact, when they write the primaries, apart from one that I know, failed pediatrics just 2 years ago, almost all of them pass it once. So they go for the primary exam and they pass it. Okay, so we are now, and now because of government's inability to post them on time, they've already started going to the USs again and the UK. So that is what then we have to now be able to do, to be able to track all those people, to be able to see what they are doing out there and how we can maximize them to support our school. So that is what, so we are in early days yet. But the tracer study is one of the things that we'll do in the next 2 years or so, when we are able to build an alumni base.
Thank you very much. So we'll end the question and answer session here. And I will invite Prof. Amini and Provost once again to help us with the presentation. This is a token saying how grateful we are to Amini. Thank you very much. Thank you very much. Thank you so much. Please, you can take your seats now. We are grateful. Yes, we can clap for them. It's not easy to present in such meetings. So we have come to the end of today's meeting. We've had 6 very important presentations. We went to industry as academia, trying to look for funding, and we've been promised that there's good news happening already. Now we came back, we looked at our curriculum. We actually looked at how to develop our curriculum different ways. We were told to change the methods, and then not to also forget that we should not fracture communication and teamwork. We really, really need to work on that. Everybody in the health sector is so important. I think we even forgot to mention the cleaners. They are all very important. If they don't come to clean, we cannot see our patients. We cannot, the pharmacists will not, they have high standards of operation. And then we came to the second session. We were told to have a sharper focus. Start from day one, look at your curriculum. Everybody should go back. Let's look at our curriculum. First page, your vision. See whether you will still work with that vision. And then we looked at the allied health service. How are we working there? What can make it better? How to, once again, focus on ethics and high standards of practice. And finally, we went to the classroom. We've learned an entirely different way of teaching. And so, 4C, team, and flips, so that we'll get the 12 CDs. So it's been an interesting day. I think we've learned a lot. One task I would give to all of us, please look for your curriculum and begin to examine it critically and see whether there are any simple ways that you can improve on it. Thank you all so much for coming into today's meeting. We have officially ended. We would please ask Dr. Peditochi to pray for us. But 2 quick announcements. Lunch is served on the first floor, and we want to plead with rapporteurs to please wait behind. Tomorrow is the 3rd day. For School of Pharmacy, your meeting will be in this room. School of Medicine and Dentistry, Bwedi Auditorium, Block A Auditorium. Allied will meet in the Allied block in this meeting place, I think on the ground floor. And then School of Public Health too will be in the public health area. So finally, we are going to our small groups at the school levels, and we'll still examine our curriculum. Thank you very much. And Provost, we want to observe the protocols once again. Thank you for allowing all of us into this very good space. And we know that we've learned a lot. Dr. Ochre, please kindly close us with a prayer.
Our Heavenly Father, we are so grateful to you as a college. We thank you for the grace that you've granted us so far. We thank you for the life of our speakers. We thank you for the knowledge that you've used them to impart on us as we live here for this day 2 of this program. We are asking for the grace so that when we go, we'll be able to
think about all that we need so that our college and our will be able to impact the industries and beyond, globally and locally. This and many more we ask in Jesus' name. Amen.
For us to be able to fast track the production of veterinary doctors in Ghana, we as a school thought of 2 undergraduate programs. First is through WASI, that we spend 6 years. Second, for those that went to Pont Tamale to do their diploma, they can come for programs coming directly to our school to spend 5 years. While for graduate entry, they will be able to spend 4 years. Graduate entry means they have done a degree in other animal science, biological science, and all that will be able to come. These undergraduate entry had been put in place in the school to aid those who have interest to read veterinary medicine. Let me quickly add, veterinary medicine is now one of the courses that immediately you finish, you get a job outside the shores. Recently, 30 of our graduates were employed by the UK government last year, and that really boosts the entry, the quest for younger ones to read veterinary medicine. So School of Veterinary Medicine of KNUST is positioned to deliver graduates that will be very good in One Health, and they will be very good in the area of pandemic control. And their training is such that they are not trained by only vets. They are trained by professionals within the College of Health Sciences, like diagnosticians, medical diagnosticians. They are trained by pharmacists. They are trained by medical doctors. They are trained also by top scientists within the college to deliver the concept of One Health system to our students. Because our students are in the school, in the college, it allowed them to be trained alongside with medical doctors, nurses, and other professions that are very critical in pandemic control. So the issue of inferiority or superiority complex is not there. They grow together, they work together, they learn to work together in solving the problem of health issues in Ghana. What then is the plan? We have 3 programs to entry for undergraduate. We have successfully, through the academic board, float 7 postgraduate programs. And one of the postgraduate programs is unique in Africa. We are talking about an MPhil and PhD in One Health. Since we are very strong in the area of One Health, using our professionals in the College of Health Sciences, that is why we floated this particular master's and PhD program. And we have connection through GWAC with DAD and other universities like University of Bonn, another university in Charité in Germany. We also have connection with AU IBA. We have connection with FAO Ghana and ICTAD FAO. And with these, we have colleagues that have also submitted to be part of the programs as lecturers. And some of them are taking areas that has never been talked about in the area of One Health, where we are talking of planning and budgeting, which makes us to know that One Health is an area of management of how do we manage pandemics. This will be taught to the master's and PhD students in this area. Second one is the Master's and MPhil and PhD in the area of integrative pathobiology. I'm a pathologist by training. I did my first degree, second degree, third degree in pathology. I also did my postdoctoral training in pathology, fish pathology, immunohistochemistry, and all that. But this is the first time I'm seeing a program integrating parasitology, microbiology, virology, bacteriology together in an MPhil and PhD program. And that is why it is called integrative pathobiology, using experts in the various areas of infectious disease to train people specifically for the control of pandemics, in the diagnosis, quick diagnosis of infection, so that once they are able to detect it early, then you can put certain measures in place to be able to control. They are not trained by pathologists alone. They are trained by bacteriologists, immunologists, and all that.